Christ. Good morning, everyone. Can you hear me? It's lovely to see you all here. And for those at home as well, I don't know whether you can see me still, but if you can, then hello. I was tired of actually seeing my face all the time online. I don't know whether you're all doing the same thing. Apart from being GP, it just helps to kind of see real people in real life scenario, and it's lovely to see real people again after a hiatus of this. So welcome everyone to the Shared Health Foundation Health Inequalities Training Day. I'm Murugesan Raja, I'm a GP. I work in 2 GP surgeries in Manchester and in Oldham, and they are all in areas of deprivation, so a lot of health inequalities that our people, our patients, our staff, and everyone faces. So we've been doing this for a long time, so at least 10 years as Hope Citadel and Shared Health Foundation has been doing it for a while. So what can we do here? How can we learn more? And I think when we finish the day, we want you to obviously, even before you do, have a bit of a laugh, try and learn things, and of course interact, get to know each other. You're all here today, so that makes me think that you're all interested in how we can address the health inequalities and how can we actually move forward the agenda that we've been moving on for a long time. We've come a long way, and there's still a long way to go. And of course, COVID exposed the health inequalities that we saw when we were kind of fighting against the pandemic. And even now, when we come out of it, or still coming out of it during recovery, we still have the same challenges. We still have the same struggles. So how can we do it together? And it's all about doing together, and we all want to be in this together to be able to make it work. So you'll be hearing from GPs today, public health experts, dentists, psychologists, trauma-informed dentists, I'm told, community workers, pediatricians, and so many of them, fascinating stories, and they will obviously show the best practice in their work, because I don't know how you feel in your day-to-day life. Every day is very exciting for me, but that's just me. But I'm sure there are challenges every day, and how can we deal with them better? So there's so many things which are packed. I wouldn't take much of the time, and I will soon ask Laura to come. But before I do that, I'll just say some housekeeping things. I think the main thing is being on Twitter. If you're on Twitter, are you all on Twitter? If you're not, then sign up today. And you've got to make sure the hashtag is #SHF Training Day. So that's Shared Health Foundation Training Day, and tweet about it so that people get aware about what we do and how we're going to do this together. And of course, there'll be lots of coffee breaks. I'm sure you've had coffee in that room, which is where we'll have our lunch. We'll have lots of breaks, and toilets are down the right. I think the men's toilet is a bit more another door to get through before you get there. And with regards to fire, I don't think there's any fire alarm today. No, there isn't. But if there is an alarm, then what you need to do is go out of there, anywhere you are, go downstairs and meet in the car park. But we're not, I mean, it's going to be an exciting day, but not that kind of an excitement. So without further ado, I'll welcome Laura Nielsen. So Laura, we all know her, but she runs, 3 companies. She's also recently, I thought she was very busy, but she's also been called or made a deacon. Yes. It's like, there you go. Busyness gets busier. Thanks, Laura.
Thank you. So it's lovely to have you guys here. Thank you so much for coming. When we put this day on, we haven't done a day like this since before the pandemic, and I was not sure if anyone would turn up. So, I mean, about 5 minutes ago, I was really grateful if no one turned up, because then we could have all packed up and gone home and we wouldn't have to do it. But thank you so much for coming. So I'm Laura, and I was going to talk a little bit about health inequalities, kind of set the scene. Is that all right? So bear with me. So I've been talking about and reading about health inequalities for 20 odd years. I think I've got some slides, hopefully, and which makes me feel quite old. You want to say no, not that old, but and the sad thing is that in the 20 years that I've been talking about health inequalities, that unfortunately has got worse. So since Tudor Hart penned his definition of the inverse care law in 1974, we've had report after report after report describing health inequalities. And The most recent one, which was published, the 10 Years of the Marmot Review, I don't know if any of you remember, but it was published a couple of days before COVID lockdown. And I went, bizarrely, in Parliament. I think everyone got COVID who went. but it's okay, we weren't testing then, so we didn't know. But we went to this kind of publication of this report that said health inequalities have got worse. And literally 3 days later, we went to lockdown. And COVID made them so much more worse, didn't it? And it really exposed our fault lines of health inequalities. And so we're kind of coming out of that phase, aren't we? And for those of us who are on the front line, sometimes it can feel a bit overwhelming, and sometimes it can feel unknown. So we thought today would be a good day just to gather. And we've got lots of different people presenting lots of different ideas. Most of them I've never heard before, so I'm really excited. And I'm really hoping that we genuinely learn. Is that all right? And we're quite a small group, so you can heckle, and you can ask questions, and you can kind of interact. Is that all right? Great. So for those of you who are new to health inequalities, where do I point this? Are we going? No? Carry on, okay. So those of you who are new to inequalities, there's some stonkingly good graphs to show them to you, if we can get the graphs up. If not, I'll really carry on. And the thing is that the way you measure health inequalities has got lots of technical definitions to it. I'm not a technician, for those of you who've realised. I have a notebook and a biro. So the way we measure health inequalities, the easiest way of measuring it seems to be kind of the average life expectancy or the age of death. And as you look at them, we have a lower life expectancy now than we had a couple of years ago. And if you live in areas of deprivation, so if you live in some of the poorest areas or you live in the richest areas, there's a gap of somewhere between 7 and 15 years, depending how you measure it. And that is true across all the country. So this is the national data. So you've got the most deprived there on the left, and you've got the least deprived on the right. And it's not really just about how long you live, because it's also about how well you live. And what we know is that if you are living in an area of poverty and you experience poverty, then you'll have more chronic diseases. Now, the NHS is great at counting chronic diseases. Just show you this. Anyway, the NHS is great at counting chronic diseases, and we like counting them because, I don't know why we like counting them really, but we like counting them. But we know that if you have 4 or more chronic diseases, that your quality of life significantly drops. And we know in areas of deprivation that people have 4 or more chronic diseases at a 20 years younger age. So we're talking about people kind of in their late 40s, early 50s, experiencing physical health of someone who's 20 years older. And that has massive impacts on work and family and prosperity, doesn't it? And this is felt actually on the front line. So those of you who are on the front line thinking, gosh, it's a bit knackering. It is. So this is the kind of consultation level required. This is the funding level required. And there is a gap between funding and our need. So if you're working in areas of deprivation, your funding doesn't quite match the need of your patients. And the Deep End team have done some brilliant publications on that. So today is about trying to find ways of reducing equality and equity. And this is the bit, this afternoon we're going to do some workshops, which we're really hoping you all actually go for. Is that all right? Because I don't want to talk to myself in a workshop. So we're going to do some workshops together where, having heard all the different speakers this morning, we're going to try and find ways that we can work together in PCNs and in our areas. And maybe if you've come on your own, then we'll find you a friend. Don't worry, I'll be everyone's friend. But we can think creatively about what we can do. There's a little bit of a window opportunity with PCNs at the moment, which I know for some of you will be in PCNs that feel like this is the dream of primary care was always meant to be. And for others, it may feel like this is a nightmare, who invented this blinking system. And some of them are really functional and some of them are deeply dysfunctional, and it's tricky. But there is a massive opportunity with PCNs and the way the health service is reconfiguring to actually do something quite creative with health inequalities. So we're going to put our heads together and think about that. Is that okay? And that's because we can change a lot. So this is some analysis that's done about how much, what percentage of health inequalities is made up from different things. And so even if we just sorted out healthcare, we'd sort out 20%, which is quite amazing. So those of you who are sitting here wondering about, oh my goodness, the coding for my EMIS system is kaput. Even if we got the coding sorted a bit better, we help the health inequalities. And then we start talking about health behaviours and physical stuff and the social economic factors. And actually you suddenly see that change is within our grasp. So some days it feels like change is completely impossible. But actually when you break it down, change is very much within our grasp. So for those of you who've heard me talk before, I always talk about a story. And for those of you who've before I've done like Harry Potter and Matilda and Duck in a Truck. That was when my kids were small. I didn't read anything other than picture books. And today I've picked a different story, and I've picked one which is a really ancient story. So it's the story of a rabbi who has gone out for a walk. And when he goes out for a walk, it says that he meets a lady at a well who's a Samaritan. So it's quite a famous story. And I thought it'd be quite interesting just to learn from this story. All right to go with that? Is that okay? Yeah, thank you. So you've got this rabbi, and he goes out in the middle of the day and he meets this woman. And it's quite interesting because this woman is getting water from a well in the middle of the day. And the only reason this woman is getting water from a well in the middle of the day is because she's like outside of society. So she can't go in the morning when it's cool, and she can't go in the evening because everyone shunned her. She's there in the middle of the day. And the story goes on to tell us that she had 5 husbands. So if you were a Victorian, you'd have thought this woman was really wayward, wouldn't you? Oh my goodness, she had no moral compass. She has 5 husbands. She has slept with the world. How awful. But if you read this story with modern eyes, what we now know is I think this woman is a woman who's probably had quite a lot of domestic abuse, who's been shunned, who's been abandoned, who's gone from one dysfunctional relationship to another dysfunctional relationship to another dysfunctional relationship. How many of those women do we see in our care? So this rabbi who has status and is important and is holy sits and talks to this woman. And you see, when you read it, she goes, ah! She goes, oh my goodness, you're talking to me. And that's the first thing that happens. And so I want us to think today about who is on the edges. This Samaritan woman is from a different place, different culture, different rules. And quite often inequalities are about otherness. They're about people who sit slightly outside of our normal, whether that's from their upbringing, their race, whether they're immigrants, whether they're people who've fallen out of our society through going to prison or probation, whether they're women who've ended up with very little choice apart from to use sex as their work. Health inequalities is often about otherness. And otherness is really uncomfortable. Otherness is really uncomfortable. But for us to get to grips with health inequalities, we all need to be like the rabbi and be willing to go and meet the other. So my first question for you today is, who is the other? The next thing that happens in the story is this rabbi says, can you get me a drink? And this woman goes, me? I mean, she's the only person sat there. Me? Oh no, I can't get you a drink, you're far too important. And so my second thing about health inequalities is, how can we create spaces of mutuality? So quite often when we're talking about people who are other, we try and do to them. We create projects for them and then wonder why they don't turn up. We create smear mornings where all we want them to do is come for a smear, but they're scared stiff and they feel ashamed because they've had 5 husbands and they think you can tell that from their cervix. So quite often we do things for people or to people out of good intention, but we don't do them mutually. And so today I want us to think about, how do we use our systems in mutuality? How do we say, can you get me a drink? Can you do something to help me? Because it builds trust and it builds relationship and it creates this different space. And then it creates this moment of change. I think healthcare is phenomenal because it has moments of change built into 10-minute blocks. I mean, it's quite relentless. But every consultation is an opportunity for a moment of change. Every time we contact a patient is an opportunity for a moment of change. And when we think about some of the psychology we're now learning about nudge theory and cycles of change and moments of change and how change can be inspired by trust, you suddenly realise that your morning surgery that might look rammed, actually, on one level, you have a whole load of EMIS alerts flagging up at you, and then you've got a whole load of other stuff coming through. But actually, each one can be a moment of change. It can be a moment of trust building. It can be a moment of compassion. Even if it's something really benign, it can be something that's quite special. And I fundamentally do believe that health is a massive pivot of change. And we're going to share later on some stories about change. I'm always amazed when I pull off the data. When we pull off the data for Focus Care, I'm amazed at how many people change. People get rehoused, people do give up drugs, people do change their diets. Diabetics actually do get their HbA1cs down again. The fact they're replaced by the next wave of over 100 makes you not see them. But they do. People really do change. And so healthcare has these moments of change embedded in it. And the other thing about the story of the rabbi and the woman was it set conditions for change. And that's something that's also we can do. So change can happen kind of randomly. And thankfully, we all have those moments where you're not the best clinician in the world, but somehow it still pans out. Yes. But we also have conditions for change. And some of these conditions will be things that we need to press into more. Who are the others? How do we find them? What's their story? What are systemic factors going on that are actually hindering people at the moment? And there's a lot of them. There's a lot of them. And the other thing that I really love about the story of the rabbi and the Samaritan lady, is that it's not someone else's problem. It's very easy to say the Samaritans, well, everybody knew the Samaritans. They were disorganized, they had lots of poor, they were immoral, they could look after their own poor. It's a Samaritan problem. And what Health Inequalities says is it's all of our problems. Now, in the public service, we're quite good sometimes at going, well, it's interesting, that problem. It's definitely a public health problem. It's interesting, that problem is definitely a primary care problem. It's definitely gastroenterology. If there was a proper consultant who saw a clinic, it would all be fine. It's definitely third sector. Or, my favourite one, which I do quite a lot in my head, is definitely Boris. Get rid of Boris, everything will be fine. And of course, all those are shortcuts, aren't they? And it's not true. And the thing about tackling health inequalities is that it's all of our problems. We all have to solve it together. We all have to be passionate about it. And we all have to be curious beyond our professional boundaries. I am not a public health expert. I have done 0 training in public health. I found the public health lectures at uni desperately dull. I spend most of my life in public health. Because that's where my curiosity is, and that's where I think change can be. And the final thing, just reminding of this story, is that it is a woman looking for a drink. And I think as we come into the cost of living crisis and as we come into next year, we might just have to be brave and say it might actually all be about utilities. And utilities might really matter in the 6 months' time. We might actually have to be a group of people that passionately talk about fuel and electricity and water and things that we never thought we would be talking about in 2022, 23. We might have to be a group of professionals who stand up and say, I don't understand how people work out their tariffs for electricity, but I do know I've got patients that aren't turning the lights on. And we probably need to be saying those stories very loudly. And we need to be saying the stories of the people who choose not to have electricity connected at all. We're starting to see it in some of our patients. And this story just reminds me that actually it might also just be about water in 6 months' time. And that's okay. We don't shy away from that. We're going to be bold and tackle it. So this is just to finish off. There are some really positive things that happen. I don't want you to all feel despairing, because I'm not. I'm full of hope. There's loads of stuff happening, and one of the most exciting things about this morning is you'll go and hear from all these people who are passionate about their areas of expertise, who are passionate about their projects, who are passionate about the work they've learnt, who've got some little secrets for us to gather in today. Is that all right? I love the idea of a trauma-informed dentist, whoever they are. Like, brilliant, wonderful. Don't we need more of them? So learn, drink it up and be hopeful. And then this afternoon, hopefully, we're going to design together some things that we can do. And this is one of my favourite quotes. And it says, perseverance produces character, and character produces hope. And sometimes, in inequalities, you have to have some damn perseverance. You have to have some perseverance, and you know it grows character. It grows character in us. It grows character in our teams. It grows character in our systems. It grows character in our relational networks that spread like tentacles and bring change. And character often leads us to hope. So thank you very much. I hope you have a really great day. And eat all the biscuits, drink all the coffee, and talk to each other. Is that okay? Thank you.
Thank you so much, Laura. As always, very inspirational, and we see that in our day-to-day lives about how it plays out. The next session is going to be a panel, which is a panel discussion on how do we do primary care well. And I think we're going to arrange some chairs and stuff, is that right? So I was thinking, how do I introduce this situation? So I'm not going to say which morning surgery, but I'll just say morning surgery. And these were my, 5 select patients who came. And, I don't know whether all of you are GPs, but then this is a normal general practice day. So the first one was Addison's disease, and they've come in with fluid in the legs, their CKD is worsening, or chronic kidney disease is worsening, suspected nephrotic syndrome, heart failure. Okay, and then the second one comes in, prostate cancer, he's got back pain, but then he's also got bladder stones, he's just had a stroke now, and he awaits further investigations. The third one, gastric cancer. These are all young people. You're probably in the 40s and maximum was 60. Gastric cancer, had surgery, now bowel symptoms, had a colonoscopy which shows polyps, which is showing again some cancerous changes. The hemoglobin is still low and they are depressed as well. And the next one, easy one, anxiety, and they had tachycardia, but it's not easy because they've had history of postpartum cardiomyopathy, so they already have problems with the heart. And that's just the morning surgery. I've just seen 4 patients so far. The fifth one is ankylosing spondylitis. The only job he could do is in a warehouse. So he's struggling to work, but his PIP claim has been rejected, and he still has to, get stuff, utilities and everything like that. So he has to work. So what do I do, doc? So they're all medical problems as well. Very easy peasy as a GP, all sorts of medical problems, but it never comes as one. I dread the question, is there anything else you want to talk about? But we all are trained to set up an agenda. Is there anything else you want to talk about? And they say, yes, 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 yes. And it goes on and on. And then you set the agenda, and then the background comes. And in all of these, half of my patients couldn't understand a word I said. They all needed interpreters, or they all somehow muddled up, with not understanding the language. So there's a barrier of language. There was a MARAC, or a safeguarding referral within that. There was somebody who was actually caring after 2 people, a child with learning disability and a husband with learning disability. And within that, there was another carer who was actually caring for his ailing mum and had health conditions of their own. So that's like just 5 patients of my typical morning surgery in one of the surgeries I work at. So that's just the scale of the problems that we see in deprivation. So I'm just really interested. So, we all become experts, like Laura says, as we keep on working. But how do you still do primary care well? And I'm only talking about the GP bit of that well. And we've got a panel with us. So Laura, are you going to lead us through the workshop? So Laura would be leading us through the workshop into that. And, if you have any ideas or anything like that, we'll be welcome. You'll be welcome to share with us as well. Oh, we can give them a clap.
Oh, yeah. Raj, are you going to join in? Okay. I feel like we need more anecdotes from Raja. Okay, so I'm really glad. We thought we'd do this slightly differently where we had some more voices. Is that all right? But also, I'm going to throw it out to you guys. So those of you who work in primary care, feel free to dib in. And if you don't work in primary care, just dib in anyway. Is that right? Pretend you're a doctor. You've all watched Holby City, so you can all do it. It's fine. So we've got Emily. So do you want to say, first of all, do you want to introduce yourself? Say a little about you. And I think we're going to go with what's your favourite chocolate bar. So your name, your job, and what's your favourite chocolate bar, is that right?
Okay, so hi everyone, I'm Emily, I'm a GP trainee, so I'm ST2 now, as part of the Greater Manchester Deprivation Programme, which is linked to Shared Health, which is why I'm here. And favourite chocolate bar, easy peasy, Kinder Bueno.
Really? Oh, gross. Right, pass the mic to
Start,
Alan.
start, start.
Alan, what's your name and where you come from?
I come from Aberdeen in Scotland, but I've been down in Manchester since I think about 88-ish, and at my practice in Glossop since 1995.
Wow. Emily, that's something to aspire to, isn't it? And what's your favourite chocolate bar?
Well, I've got to be careful with favourite chocolate bars, but I might break my promises for a chocolate Easter egg.
An Easter egg? Oh, yeah. I love an Easter egg. I don't know how the chocolate tastes different just because it's round. It seems to, doesn't it? Right, go on, Raja.
What do you want me to say?
Wait, your name. Come on, get with the programme. Your name, where you come from, what's your favourite chocolate bar? It's a good job we've got 10 people on this panel, isn't it? It'll take a while.
I'm Murugesh Raj. I'm a GP. I've been a GP since 2011. So it's 11 years now.
There you go.
And yeah, working with health inequalities for that long time. My favourite chocolate would be a Toblerone.
A Toblerone. Well, the good thing about Toblerones is you can get massive ones, can't you? Yeah, the ones in the airport that you think, why did I buy this? I didn't need it really. Okay, so we asked you guys to just share a little bit. So I think about what do you think good primary care looks like in areas of deprivation. So Alan, do you want to kick us off? You can go first with all your experience.
It was me thinking I was safe in the middle.
Oh, there you go.
So I thought I would just say a few things that we were lucky to introduce in our practice, more or less when I took over in 1995, and that have worked for us. I do practice in an area that would be classified as one of the high areas of socio-economic deprivation, and have done since, and very much have loved being in a small practice with a population I know, and I think that probably colours what I'm going to say. But first of my 5 points was to give a shout to our practice receptionists, who I think have really been the front line of general practice primary care, especially during the pandemic. But a team of people who actually want to help people and know who they're talking to, fantastic, irreplaceable.
Have you ever sat on reception, Alan?
Well, I think my receptionists try and keep me away from reception, because it's not something I'm very good at.
No. I offered to help, and now if I literally sit down in the chair, it's amazing how many people appear. Oh no, don't you, Laura, off you go, out of the way. So, yeah, definitely moved on. It's difficult, it's a really difficult task, isn't it? But that thing of having people that want to help, that care and know our population, our patients is so important, isn't it? Great one.
So my second point would be that we've had a completely unlimited urgent offer to our population since I started. So pre-pandemic, that would mean there's none of the 8 to 9 phone call rush. There's none of the we've seen as many people as we can. It meant the door was open from 8:30 till 12:30. And if you have an urgent problem, you came in. Latterly, since the pandemic, that's turned to an unlimited telephone offer. And I think the open door proved it is doable. There are a lot of people that say demand is infinite. But I can tell you, if you leave the door open, eventually people stop coming through it because the day's need has been met. We've found it really complicated, sort of post-peak of pandemic, because we're getting a lot of urgent problems from the supermarket or urgent problems while I'm out shopping in a mall. But before that, when people presented with genuinely urgent problems, demand is finite and you can meet it.
That is really challenging. Yeah. We have not quite managed to do that yet, but I will keep thinking about that one, Alan. That makes me feel a little scared, if I'm honest.
Yeah, I wouldn't like to be starting it now.
Oh, good, great, thank you.
But knowing that it has worked, we are buckling a bit, as I say, with some of the. It's easier to be urgent on the phone. I think we haven't worked out how to come to terms with that yet. And then when you actually say, it's not urgent, it should be a routine appointment, I think then it's all very difficult. But that would bring me to my third point. And I think especially in the context of the day, people with lots of problems need longer time. We've always run, well, not always actually, we introduced a 15-minute routine clinic some years after I started. We started with one 15-minute clinic. When we saw it worked, we changed all the doctors' clinics to 15 minutes. And at the moment, we're even experimenting with one that's running longer than that for people with multifactorial problems. But also, during those longer appointments, we don't limit the number of problems that you can come with. If you do choose to come with 6, well, then you've chosen 6 problems. They all need addressed. Why not just do it at the time? Why put it off and address them later? So that balance of an urgent offer, which is often quicker appointments, and a longer, more in-depth offer, I think covers a lot of bases, and it lets you explore things in more detail. It gives people more time. And as that fantastic quote you had as well, it is a moment, isn't it? It's an opportunity. And a bit longer, a bit less pressure, a bit easier to take advantage of the opportunity.
It's interesting, isn't it? I really like the fact that, I mean, Alan, you've been doing it a long time, and you get the sense that you're still learning and still changing stuff. It doesn't sit still, does it?
Well, no. I mean, the pandemic, I think showed some of the flexibility of general practice at its finest, that we could adopt things that we might have thought about for a long time, but were forced to change and just changed within days, within hours. We're so lucky there was some good modern technology at the same time. But if we hadn't been the kind of organizations that could pick it up and run with it, wow, where would we have been if we could only work to the old model? That would have been a disaster.
It's amazing, isn't it? Right. Is that 3? Have you got 5?
That's
or
3.
7?
I've got 5. I can speed up. So the fourth one would be, and again very pertinent, the offer of continuity of care. And I should confess, I'm Honorary Secretary of the Family Doctors Association, and that is the raison d'etre, really, of that organisation. But there's so much proof for it, and yet, sadly, it often isn't reflected in our public policy. We know it does so much, as well as increases satisfaction for patient, clinicians, frontline staff. And again, to mention reception, of course, continuity isn't just about doctors or about clinicians, nurses. It begins with reception. And we tried to do a few technical things to maximize that. So even in our urgent clinic, we try and give people choice of doctor. But then when we see people in our routine clinics, we do the direct booking ourselves. We arrange the follow-up ourselves. And we keep things with the same clinician of the patient's choice as much as we can. And the last thing is there's no point in continuity, though, unless you actually have a good offer for people. And I think the offer is patient-centered care. And I have seen that term very much used as a label to make something right, to sell a campaign. But actually, if you only see the medicalization and the medical problem, and you don't see the person in front of you, as a family doctor, I think you're missing the point, really. The person that comes with the context of their psychosocial problems, their life, their experience, you've got to see the person. If you only see the problem, you're doing a very small part of the job. That would be my 5 points.
That's it, yeah. And I think my experience is that even the most broken people are beautiful, aren't they? You know, so if it's just a problem list, it's overwhelming, isn't it? Like if it's always like problem, then it becomes very much about you solving problems. But if it's about a person, then some of the problems might not be solvable, but there's still kind of beauty in there, isn't there? So, right, Alan, remind me to never come and work for you because it sounds like the bar is quite high. But that's brilliant. So continuity, access, talks about a relationship really with the receptionist, with the whole team, and giving people time to be human really, isn't it? That's great. Raja, what top tips have you got for us?
I think more than top tips, I mean, sometimes we talk about the definition, if I come just from a GP angle, often called as the gatekeepers, or I think there was some debate in the council recently and they were talking about us being the navigators of care. And I think, this might be just an anecdote or observation that we're kind of becoming, because of the pressures and the demands, that we're becoming like a traffic policeman. Oh, this issue, you go there, this issue, you go there, this issue, you go there. But then this is not my idea. I always learn from someone that we as GPs, including all the staff, we own the patient or we own the house. I think we're all probably, some of us are fortunate to own a house. And the example is if the plumbing goes wrong, I call a plumber to fix the plumbing, but the house is still mine. And if there's something problem with the boiler, I call the gas man and he fixes it. The house is still mine. So I kind of think the same with our patients, because even though they might have a urology problem, which I may need some help from the urologist, but I still own the patient. He's mine or they're mine. I need to think about what's best for them, and we need to work out a plan on what works best for them. So I think it's all about the relationship building, knowing about them, because the Addison's disease or the nephrotic syndrome or the heart failure doesn't mean a thing if you don't really understand that they actually have to go back home and care for their children with learning disability and still live in that difficulty and then forget not being able to afford the utilities that we talked about. So how can you be a navigator of care, or you need to go to nephrologist or you need to go to the cardiologist? That's not going to work. You just have to understand them, build a relationship with them, care for them. Few words, moments of change. And then, of course, they really want to see you. And then how do you create that access and that barrier of access? I've kind of worked with models where we did the urgent calls, but then we realize it's the same patients keep coming again and again, because it's just that you've never addressed the whole of it. You've never addressed the whole person. And I think that's what's more important, in my view, about general practice. So we become not just gatekeepers or navigators of care. We become, the friend, the doctors, the one who actually cares about them and one who can treat them. And sometimes they come in, you've never really sorted anything out for them, but they still go out much more happier and with a bit of hope. And that hope kind of carries them through possibly the next couple of days, and then they're back again within the life that they live in. So I think as GPs, we're challenged to think, yes, we are pressured all the time, but I think we have a very important role. And that role kind of transcends. Once you said the example, then of course, the practice nurse is great inspiration for us. Receptionist, a good receptionist can make so much things better for our patients because they know everything about them. And I often talk to them about them once, if I'm going to see them for the first time, and they often give us a lot more detail that is so much important for us. And working in a place where I work, where we have focus care workers, it's just helpful because I can't sort any of the social problem, but it all needs sorting out. And if you can't do that, then of course, how are you going to treat all the medical problems that I just highlighted? Because it just becomes increasingly, it's the challenges are increasing. And I think that just gets more busy. And lots of people are coming in with problems now that they are struggling with the system, whether it's barriers to access to us or to secondary care or to wherever, or access to even simple things like utilities that we talked about. So how do we break those barriers? And these people are the same ones who've already faced so many barriers in their lives already. Even to come and sit in that room to see me, I tell you, it must have been very hard, especially the young ones who come, or even the example of the Samaritan women that Laura gave, I see them all the time. Even a big challenge to even say the first word on how, this doctor is going to be. And you can make it or break it in that exact moment of change. So each consultation is important. Yeah. You never know what sits behind that person. You just have to pause, give them the care, And for that, I think more important is to care for yourself. And I think I've just realized that you've got to look after yourself, because if we are kind of stressed and running around, then where can we get the empathy from? Where can we get that understanding? Where can we get that care from? We have to look after ourselves to be able to do that. And we need to kind of work in places where there's, there's talk about well-being, where there's talk about how we can look after ourselves to be able to look after others. And I think that's the challenge we all have, during this time. And we can't blame any one single thing. It's easier to blame.
It's always Boris.
I can always blame anything that we want, but sometimes I just blame the chair that I sit on. It's never comfortable, and then you still carry on. But it's a challenge, Laura. I don't have all the solutions.
No. I love the idea of you muttering to yourself about your chair, Raja, and then cracking on anyway. So there's lots in that, isn't there? So we're going to unpack some of this later in the day. So looking after ourselves is really important. Seeing the whole person, trying to remember that it is quite brave to go and see a doctor or a social worker, or isn't it? I don't know if any of you. I was a patient a couple of weeks ago, and I'd booked off the last hour of the day, and by the time I got there, I was like a gibbering wreck, and then I burst into tears before I said a word. You just think, oh, for goodness sake! But if that's me, by the time I came out, I was sat in the car and I was like, oh my goodness, I definitely need a dairy milk. But yeah, that kind of, it's brave, isn't it, to go and say things that are vulnerable. And I think when you sit the other side of the chair, I know when I see patients that I can get irritated when they do the, 3-minute build up to the actual point. You're like, come on, what's the point? But when it's you forget that you suddenly remember, don't you, how vulnerable that is actually. Right, Emily, you're our newbie. So we're going to leave you a quick, anything you want to share about, like, from your short experience of general practice, things that make it go well.
Yeah, correct. Very short experience so far, sat alongside lots of wealth of experience. But I guess I'm here to sing, dance and talk all day about the Manchester deprivation training scheme because I love it. I think it's brilliant. And what makes it different from other training schemes, GP training schemes, is that our placements and our teaching is very much geared to developing the tools and the resilience, I guess, a bit of a buzzword, but the resilience to sort of work with these populations and try and tackle some of the problems that we've touched on that I'm sure we'll talk about more later. But basically tackling health inequalities and having the ability to sort of stay working in those areas. And I think that's been proven already. A couple of our friends that have CCT'd recently, they've stayed at the practice that they've trained in, in areas of deprivation. And that is down to the training programme. So yeah, I'm happy to talk about that all day if anybody wants to come and chat later.
Yeah, so I said when we started the deprivation training scheme, we're like, it's teachable. Working in these areas is teachable. It's infectious. We talk about it like it's best to surf when the waves are highest. Nobody wants to surf in the, when the waves are piddly. So, but to learn to surf, you have to have some skill. So it's teachable, it's infectious, and I want to be a doctor that is still seeing patients in 20 years' time, and loving it still. And that's what we want, isn't it? So a few things for me, for those of you in the room. I have become a convert to the power of Arden's searches. So I'm not the most technical person, but the stuff about, access and compassion and relationship and everything is absolutely brilliant, and I will always hold that up. But just to balance that, I've also become a convert to the power of using data to find those who haven't been found. And we've run various searches at our practice in the last couple of months and found people who actually are right on the fringes, and we, if we'd waited for them to tip up to us, that might have been another couple of years, but we found them and called them in. And we're still, some of them we're doing that journey of, we've called you, or you're not coming. We've called you, you're still not coming. But they're interesting that they're there. So the power of our data to find invisible people, I think, is really important. And the other one I love is that we don't exception people in QOF until the final week, and you have to have this. The bar to exception report is quite high, but I love it because in some of the practices that are a bit more kind of on it, that last week we send the nurses out door knocking, And they go and door knock on the people we haven't seen all year. And they're often like the people with like 10 chronic diseases who you think got a leg hanging off somewhere in the living room. And they go and door knock. And that week is like amazing week of finding people. So you don't get the quaff points because it's too late to do anything. But it's like the time of the year where we find them, we know them. They're suddenly glaringly there on the computer screen in every search. And then we set them up for the April. So it's just cyclical things that kind of help keep you going, really. And there's nothing like knocking on a door and finding someone in an absolute desperate situation and knowing you found them. Like we've every year in March, we find people who've had electricity cut off, run out of food, living with like infestations, abandoned by family, living surrounded by cans of cider or whatever. And to know you've knocked on the door and you haven't solved the problems and it's still going to be there next week, but at least someone knows they're there and they care. For me, I love that week. So I hate the coding, but I love that week. So has anyone else got anything that they'd like to share? We've got a couple minutes, so anyone sitting here, let's pull the wisdom. Anyone who's got any ideas of making primary care work really well? Oh, good. I'm excited.
Laura, I can go.
Yeah.
Like the dentist table. What are Ardens?
Oh, yeah. Oh, sorry. Sorry for the dentists. Oh, I'm really sorry. I've been talking in gibberish all morning. So primary care has a computer system called EMIS, which is brilliant, much better than the hospital system. And it's got really good coding in it. Some geeky GP invented it in like the 90s, and they're really good. And then Ardens is this new software that interrogates that. So you can find anything. It will find you people with like 6 left toenails and a squiffy nose. It can. So it's the power of it is amazing, and it does these searches, and it also interrogates all the results data. So if you find people with like, I don't know, platelets of a certain number, it will bring them up. So it's new. It's landed in our practice in a couple of years. It looks really frightening. It looks like when you go onto the Ardens screen, it's like watching teletext from the 80s. It's just like lines of numbers and data, and you're like, oh my goodness me. But underneath it, it's amazing. Teeth is fascinating. We've got you guys here because teeth is... we have primary care coding for like mouth ulcers and suspected cancers and things like that. We've got some for terrible, caries, and we code letters. So we do code children who've had teeth extracted. But yeah, teeth is something that we've got you guys because we know that if you look at, I think a marker of deprivation and inequality is teeth actually. And it follows, doesn't it? When we see our childhood carie rate go up, a couple of years later we see our diabetes rate go up and everything else go up. So it's like, for me, it's like an early warning system, teeth. And our public health data on teeth is appalling at the moment. So we're really glad you guys are here. Right, any other questions that I've been gibbering on in gibberish about? No? Oh, go on, Liz. No, then. Can I ask Alan a political question? No, Liz.
Just about, it's really about the funding and the differential funding. There has been something in the GP press recently that there may be more consideration for, or acceptance, realisation that deprivation needs more funding. Is that a dream, or is it likely to become a reality?
Do you want to answer that, Alan, or shall I say it's time for coffee? A little bit. So this is we're not going to go down a funding thing, and the other rule of the day is if the fire alarm goes off, obviously go out the building, but the other rule of the day is we're not going to turn into the whingy people. All right, Liz? So funding is always a pain. Right, you've got 30 seconds on Liz's funding question.
Did you say 5 seconds? Excellent. 5, 4. So there have been various variations over the years of trying to move funding in general practice, that's the only bit I know about, into areas where there are higher levels of deprivation. And one of the things we know with the retirement crisis of general practice at the moment is it is primarily GP partners that are retiring, and it is primarily in the areas that are worse off. So we already start from a very bad place, and it's accelerating the most in those places, exactly the opposite of what we want. I think the difficulty with moving funding, unless you can level up, there are always losers. And actually some of the equations that have been used and complicated before, where you just think about one aspect, you can forget other aspects, and that doesn't work. So we learn that if you only look at just general practice again, funding in areas of poor health, what about areas where most of your population is a lot older? And they might really be well, but actually they're not really well, because if you've got an old population, you've got lots of problems there. I think the world we live in is so complicated with so many different angles that addressing it properly is a big consideration. And that's why there haven't been, I think, great clear strides, because it's difficult. I do remember a few years ago when there was a waiting to work in areas that were harder to work in, which does seem to link with some of the activity that you see as a GP, that it seemed to be beginning to move general practice to the right people. This Manchester deprivation training scheme, fantastic idea. It's an example of a different way of doing it. And people staying on. We in our practice have had so many people staying on with us after they've done the registrar year. Maybe not forever, and then they go on somewhere else. But initially, I think that's a big thing. Training people, getting people into the areas where they're needed most, and then them staying on. There's a possible future in that.
So we are going to, any other burning questions? Well dodged, Alan, a good answer. So we're going to hear from Jen Davies now, who is a psychologist, to talk about compassion in healthcare. And then we're going to have a little break, I think. Is that right, Roger? No. Right. While Jen's like walking up elegantly, why don't you all just stand up and do a little wiggle, and then we can sit down again. Is that all right? Just have a stretch for a couple of minutes, and then, because Jen is amazing, and I want you to listen to her.
Has everybody wiggled? Good. We'll just wait for the slides to emerge. Thank you. I'll just try and skip back a bit. Oof, marvellous. So hi, I'm Jen, and it's been nice to meet the people that I met already this morning, and look forward to meeting other people as well as the day goes on. I'm a clinical psychologist by training, and I'm based in Hawthorne GP Medical Centre. So I run an infant parent mental health service there. And the idea is that we're kind of based there in the GP surgery to try and reduce stigma and increase accessibility and kind of overcome some of those health inequalities that prevent families being able to access care and support in that period. So I love chatting on, like Emily loves chatting about the GP deprivation training programme. I love chatting about that. So if people want to talk about that in the day, come find me. I'd love to have a good crack about it. What I'm here to talk about today is a model that I find helpful in my clinical work with families, but I also find it useful in my relationship with colleagues and in terms of thinking about organisational stuff as well. And that's the compassionate mind training model. So I'm sharing that with the hope that it might be of use to people, whatever their role is within healthcare. Because we know compassion really matters, and we've heard about that this morning already. People have been talking with huge compassion. And I guess, you know, this is what the NHS was built on, isn't it? And healthcare is built on this value of offering compassion. And we know, unfortunately, when it's not around, that often, and things go really badly wrong, when we unpick it, we can see that a lack of compassion has had an impact on the patients who might be accessing the care, but also on the staff working in systems that have been stripped of compassion. And also it costs more money as well. So on all levels, we know, you know this, we're talking to a room of people who know this, that compassion matters. And that's why we've had people like John Ballot, Pam Camplin, writing for over decades about the importance and the cleverness, the intelligence of having like compassion and kindness in healthcare. But more recently, what we've seen is some research that's looked at why does it make a difference? And we heard just in the panel about kind of how you're talking about kind of within primary care, real active compassion making a difference. But how does it? What are the mechanisms that make that difference? So that second bullet point up there, I hope I say this right, Trzekiak, I think, and Mazzarelli, they did a review where they pulled together different research to look at how does it make a difference to the people who are coming in to access care. And they found 20 different mechanisms. So they talked about how the practical stuff can be different. So if people are engaged in compassionate care, then we know that actually there's much less likely to be serious medical errors because the quality of care is increased. We also know physiologically it makes a huge difference. So they found that when compassion was involved in care, patients reported lower levels of pain in terms of their immune responses. If they had things like a common cold, it was likely that the symptoms would be less severe and they would last less long. Things like stress-mediated diseases, they found that sugar, there was optimal levels for diabetes as well when there was compassion in the care. They found these pulling together this research to show how it's really having an impact. And relationally as well, there's some evidence that the mechanisms work in that if compassion is there in the interactions that we have with people, then actually the patients are more likely to adhere to treatment plans. And there is evidence that actually it's better for practitioners as well, that there's less burnout when we operate in a compassionate way. So these are all the things that you know as a room of healthcare workers. It matters, compassion, obviously. But I'm using the word because it is used quite frequently, but what do we mean by it? So this model that I want to just introduce, and that will hopefully be of some use to you, uses the definition that's provided by the Dalai Lama here. So I've got a picture of him on there. And it talks about having a sensitivity to the suffering of self and others with a deep commitment to try to relieve it. So often when people talk about compassion, there can be a little bit like, oh, that's a fluffy or easy thing to do, or there might be a bit of eye rolling. But actually, compassion is really hard to do. To actually turn towards the suffering instead of turn away, take something, and to try and do something about it. Now, you do this on a day-to-day basis, don't you? But it's no wonder that we're knackered. We're really tired because after a day, it's not just about the long shift. It costs something to do it as well. You know, we have to draw on something in doing that as well. It feeds us, it nourishes, it's rewarding, but also it's not an easy thing to do. So that's an important thing for us to remember, I guess, when we're thinking about this. The other important thing to remember about is that we're wired for it as well in terms of compassion. So if we can do a bit of audience participation. So when a baby's born, what do they need in order to survive? Just shout out anything. Milk? Fantastic, thank you. Anything else? What might they need? Warmth, did someone say? Oh, anything else? Fantastic, that's good. Protection, yeah? And how do they get all of those things? Milk, warmth, protection. Yeah, from another. When we're born, unlike other animals, where you see they're born, nature documentaries, a couple of hours later they might be running around, that's not us. That's not how we come into the world. We are designed to connect with another. That's how we survive. And that's true not just of us as individuals, that's true as humankind. We're reliant on each other, and we've been sold this thing that we're all competitive, but actually we're designed to connect. We are designed to live in communities. And if we think about the climate crisis, as the last quote on there says, love and compassion are necessities, they're not luxuries. So that's, I guess, what we're thinking about when we're thinking about compassion. Obviously, lots of definitions around compassion, but there's also a bit of neuropsychology that Paul Gilbert, who designed the Compassionate Mind training model, he draws on a lot of neuropsychology as well as some evolutionary theory. And there's 3 main points that it might be worth us hanging on to today. So it might seem quite basic, but the first point is about us having the capacity to experience really strong emotions. So we might feel those emotions in our bodies, and we might talk about gut responses or our heart responding, but there's also an awful lot going on in our mind when we're feeling these emotions. So you can see here we've got an image of a neuroscientist, Rebecca Sachs, and she took a picture of her kissing her baby in an MRI machine. This took a long time to achieve, by the way. And you'll see she's overlaid on it the bits of the brain that fire up when we're trying to figure out what is going on in another person's brain. So when we're trying to connect with someone. And this is the second really important thing, is because our brains are wired to connect to each other, when somebody, for example, like stubs a toe, we might get that like, ooh, kind of response in us. Or when we see like a kid hug another kid or offer them comfort, we might get that, oh, kind of response as well. That's what we're designed to do. You know, that's part of what our brains are trying to do and make sense of what's going on. So that's the second important point for us to remember, which might be useful for thinking about this model. And then the third point I think that's important to hang on to is this idea that we have the capacity to experience strong emotions, not just because of what is happening now, but because of things we can remember as well. So, you know, if we've had a big row with somebody, when we think about it, we might get the same sort of like, oh, I'm still wound up about that. And we kind of get that same bodily response that we did. Or if we remember something scary, we can get palpitations. I'm just going to flick back. Or happy things as well. So that can have a real impact on us. So they're the important things to remember. So Paul Gilbert, who kind of pulled this model together, he said in order for us to kind of make sense of this, so because we've got all this complex stuff going on in our minds, we've developed these different emotion regulation systems to help us manage them. So he talks about the threat system, the drive system, and the soothing system. So the threat system is that system that has come into being to keep us safe, basically. It is on high alert. It is looking for danger everywhere. So it operates on a better safe than sorry principle. So if we think about our ancestors and we think about where there might have been a rustle in the bushes, much better to think, okay, I think that's probably a predator, rather than it's the wind. So that kind of neural pathway system gives us a hit of cortisol and it makes us ready to fight or flight. Yeah, we're going to have a fight, we're going to run away, we might freeze. So we've got that emotional regulation system within us. We also have the drive system, the blue one, and that one is about seeking resources in order to survive as well. So that's about going out and getting things. And that's accompanied, when we've done that, we get a sense of achievement. And that's accompanied by dopamine, which is quite a nice thing to get a hit of. And so you can kind of get really into that and you can go into overdrive. I get a lovely dopamine hit when I've been food shopping and I open my fridge and it's full. That's the thing that I get, yes, that feels good. So we've got the drive system there. And then we've also got the soothing system. Now this is when the threat system is not in action, so there's no danger. We've got everything we need, so the drive system's not trying to function. We're just really soothed, calm, okay, connected. And hormones like oxytocin are kind of associated with that system as well. Is that, I know I've whizzed through that, and so it's a lot of talking, but is that making sense? Do shout if I'm just talking nonsense and you want to ask a question or anything. So they're the systems that are going on for us. Now the idea with these is that our different experiences exercise these different neural kind of emotional regulation systems to a different level. Okay? Oh. I'm obviously not talking quick enough. Go back. Yeah, they exercise our systems to different levels. So a bit like walking a path through grass, the more you walk it, the flatter that grass becomes, the easier it is to walk. So these systems become quicker to trigger the more experience you have of those systems being triggered, if that makes sense. So society-wise, which systems do you think we exercise most? Drive. Yeah, lovely. There's a lot of stuff, isn't there? If we think about advertising and how that functions, do this, and you might be happy. If you have this, you'll be successful. If you do this, yeah, wonderful. Any other systems that you think we might exercise? Yeah, red threat as well, yeah. And we can see that if we look at kind of media coverage of things, there's a lot of threat, isn't there? There's a lot of reporting of threat, and there's a lot there, yeah. And nobody really said soothe, which is interesting. It feels like there's something that we've kind of lost or are missing, not everywhere, but it's harder to see that more broadly. Now, if we think about this in the context of health inequalities, what would we say is being developed for people who are struggling against all sorts of stuff there? Red, yeah. Threat is high. It's high. And I guess thinking about my infant parent work, I think about the Embrace support, which looks at maternity outcomes, and that is just staggering in terms of the differences depending on where people live, less affluent areas, if they're kind of growing up experiencing systemic racism, other inequalities, much harder to have positive outcomes. So threat can be really high. So let us get a little bit more audience participation because we're nearly at the break. I want to keep you with us. So if we think about a hypothetical patient, I'm going to ask you what you think their systems will look like. So this is Kaylee. She's a 19-year-old woman, and her dad lost his job when she was a kid, and then the family started to struggle financially. Conflict grew between parents, and then violence escalated, and her dad ended up being sent to prison for a serious physical assault against Mum. Mum struggled to care for her, and there were issues of addiction, and she was taken into care when she's 12. She often got into trouble at school and in kids' home as well for lashing out and running away. This sounds something recognisable to people? Yeah, okay. Currently, she's struggling to manage money, and she moves between friends' houses as well. So what do you think her emotional regulation systems would look like? If we think about one being more exercising, the other, which one do we think might be exercised most? Yeah, absolutely. So threat is large. So just as Laura was saying about going into a healthcare setting, being a place that can trigger threat, let's imagine Kaylee's coming into some sort of healthcare appointment, and she goes in and there's already a queue at reception. What do you think might be going on for her there?
She's feeling insignificant. She's not going to get what she needs.
Spot on. Already, yeah, already she's feeling unseen, that she's not going to matter, there's a queue. She waits in the queue, she gets to the desk, and the phone has been ringing, and the poor receptionist is on her own, and she's been trying to do it all, and she goes to reach the phone. What do you think Kaylee might do in that moment if she's just got to the front?
Hit out.
Yeah. Hit out, and was there something else? Or leave, yeah? Fight or flight. Kick off or leave. Because your threat is so high, why wouldn't you do that? That is what has been exercised, that is what you do. Absolutely. So now let's think then about if we have a hypothetical healthcare worker. Let's think about what their systems might look like. So let's say we've got Mariam, first person in her family to go to higher education. Family very proud. She did really well at school. When she got to further study, that was much harder, but she was really determined she was going to stick at this because she really wanted to have a job that would make a difference. She's always been known as the caring one in her family and friendship groups, and she works for really long hours in this role, as well as continuing to care for others outside in her personal life as well. I don't know if there's some recognition in the room there. There's some smiles on faces going, But what do you think Mariam's systems might look like? Which ones have been exercised? Love it. I love that. Sometimes that gets missed, you know. But there's something about us in offering care, we also exercise the same system. So that's the bit that's rewarding for many of us in healthcare, is that actually by offering care, we're stimulating our own soothing system. So brilliant. Any other systems that you think might be activated? Drive, spot on. Yeah, drive, because we can see how that has become something. And there is a kind of a bit of a dopamine hit with this, that rush of achieving, of doing. So what do you think it's going to be like for Mariam if she's working in this healthcare practice and Kaylee's just like, no, I've had it, I'm out of here, or is kicking off? What might get triggered for her? Threat, yeah, absolutely. And this is where we go back to those underlying principles about how our brains are so interconnected with other people's, and they're powerful. We read what's going on for each other, we feel it, we experience it. So what the compassionate mind training model might suggest is that if we're able to spot that in action, and you'll know this, but if we're able to spot that in action, we might be able to intervene in some way. So if we can visualize, okay, this is someone in threat, that might actually help stop our own threat system being triggered because it's so quick. Like our amygdalas are designed to pick up on threat really quickly. But if we have a model where we can understand what's going on in theory, maybe we can do something a bit different. And maybe we can exercise and grow our own soothing systems as well. It takes practice though, it takes a long time to kind of walk down those paths of grass and make them more easy to access in the moment. But there's some references at the end with links to the website where you can kind of access different exercises that do just that. And the idea being that if we become more soothed in the moment, which I think we heard examples of in the panel, then other people will feel more soothed in our presence as well. And also, I guess, the compassionate mind training gives us a scope to think about what that could look like organisationally. So this was, what I think you said it, Laura, moments of change. And this is from Karen Treisman's work on trauma-informed practice, that every moment and interaction can be an intervention. And I absolutely agree. I think it was Ian, we were doing the shout out to the receptionist. I absolutely agree that that's just so key. Time and time again, I've seen people come in high levels of distress. And by the time they get to the healthcare practitioners sat in the room, they've been soothed by amazing reception staff who'll say, "Oh man, it's been such a long wait. I'm so sorry. Would you just give me a moment because I really want to hear you properly. So if I answer the phone now, I'll be able to pay attention." And they've done this soothing before they get in. That's every moment that you have the opportunity to do that. And it is a whole kind of team thing. And we've got the evidence to show that if we're able to do that within interactions, it really does make a difference. So Trzekiak has a TED talk called 40 Seconds of Compassion. And they looked at it was in oncology care, they did this research, and they found that if they had 40 seconds of compassion, a little bit at the beginning, a little bit at the end, they had much better outcomes in terms of well-being for patients. So if we just have a look at this and think about what you could do or probably do already in relation to these words, I'd just like to share how much of a difference this is actually making, really. We know this makes a massive difference. So in this example, the words they used were, "I know it's a tough experience to go through. I want you to know I'm here with you. Some of the things I say to you today may be difficult to understand, so I want you to feel comfortable stopping me if I say something's confusing or doesn't make sense. We're here together and we'll go through it together." So there's something about the togetherness, there's something about saying you can ask me questions, and there's something about recognising that it is hard for them to be there. If we're able to do that, it will make a real difference in terms of our patients that we're kind of working with as well. And finishing with that at the end of the interaction. So 40 seconds, that can make such a big difference. So I guess that's one thing that we can all remember that we may well be doing already, but just hanging on to the fact that we're doing that and it makes a difference is good. But just as we've kind of also talked about, we can't do that unless we looked after ourselves. Raja, you were saying about the importance of self-care, and I think that's so key. If we think about stress as being symbolised by water here, and if we pretend this top bowl is the patient coming in and they're spilling over with the stress of life, and we as a practitioner might try and catch that, we're the middle bowl here, and we're trying to catch that. But if we're too full, we'll just spill over. So we need bigger bowls to be able to tip out. And I guess that's worth us thinking about who are our bigger bowls within the organisations where we work, where do we do the tipping out so that we can then contain the stress of the lives that is coming in towards us as well. So that's a question that we might want to think about a little bit more in our own settings. And then finally, last slide, thinking about organisationally, we can do the stuff we can do individually, but if we think as an organisation, it can have so much power. So this was written about in the Harvard Business Review, and there was a failing healthcare organisation system in Michigan. It was in America, and the CEO decided he was going to do things differently. He said to people, "Okay, I want you as staff, I want you to bring your heart to work and make heartfelt connections. So I want you to say who you are, what you're doing, but also a heartfelt why. So the example here is, I'm Tom, I'm here to change your dressings because we want you to get home in time for your granddaughter's wedding. And it was that bit at the end that made the difference. It's like, I see you, person, which we've already mentioned about, and I care about you, and I want this to be different. And what they did role plays to have a go at doing it, and then they had a go at doing it, and then they celebrated when they saw their colleagues making heartfelt connections, and they had little red hearts. Now, I'm not sure how this will translate from America to Britain. We might have to rethink how we do this. But something about spotting that in action really made a difference. Gorgeous examples in the paper of like a nurse where a man was kind of kicking off in reception, and security had been called, and the nurse had just done a role play, and she'd kind of walked up and she went, "Do you want a hug?" And like he was like, yeah. And sort of when really upsetting, his wife had just had this really horrendous diagnosis, but she was able to hold him. They didn't need security. And that all stepped back. Another lovely one of the receptionist changing what she said from being, you need to come back in 2 weeks, to the doctors would like to invite you to come back in 2 weeks. Tiny little wording, but it just made people feel valued. And that made a real difference. So they saw scores improved, it says there, on-call light responses, pain management, discharge planning as well. So satisfaction rates went up, clinical benefits went up, all from kind of those heartfelt connections. So though I'm definitely preaching to the converted here, and this is what people are doing, but I guess it's just worth remembering when we do it, it has real impact. And I think it'd be lovely if we could spend a bit of today celebrating that as well. Okay, thank you.
Thank you so much, Jen Davis. Thank you very much. I mean, I have the fortune of working with Jen, and I already use all of these things that she was talking about, and it really works. It really works. And then she put up a YouTube video about what she does, and I think one of the comments from the practice was that we need lots of Jen Davises in our community, in our practice, in our places. So big round of applause again for Jen. So everybody keeps mentioning coffee, but coffee is at 10:50. So please be aware of that. But I wouldn't take long before I introduce our next speaker. We've got Beth Myring and Natalie Lane, and they're going to talk about community healthcare. So they basically run a small Christian charity called Life Centre Salford, and they look after tummies. So they feed hungry tummies. So they've fed about 2,000 children, and they're working in the Salford Holiday Hunger Program as well. So there's a lot of things to learn from them. So to invite Beth Myring and Natalie Lane. So again, a big round of applause for them.
Good morning, everyone. We want to apologise that we have seemed to have disrupted the coffee break. And we know that that's going to be difficult. We have got a couple of videos in our presentation, so we're hoping that will ease you through that bit of time. It was a delight for us. We've just arrived from doing our breakfast group provision at our community centre to hear the end of Jen's presentation there. And we would say yes and amen to everything that she said. So we're from Life Centre Salford. I hope, will it come up behind us? I can see it in front of me. And so we're a small community centre, Christian community centre in Salford. We've been working there since the year 2000. I've not been there that long, but Natalie actually has. And the majority of our staff and volunteers live within a mile of our building. It's a very hyper-local focus. It's a deprived area, but our vision is to work alongside local people for community transformation. And we hope that today we're going to give you a few ideas from some of the projects that we run about different ways to address health inequalities than perhaps you're used to hearing about. And if you are used to hearing about them, then hopefully you'll hear more. So we're going to give you an overview of 4 of our projects.
Karen, why do you run?
Because it makes me feel good, and if you could switch me off then.
I thought you'd finished. Karen, why do you run?
Because it makes me feel good, and if you could switch me off then.
I thought you'd finished.
She was in a stride then.
Go on, start again. Why do you run?
Because it makes me feel good, and I don't know, it's the happy hormone, isn't it?
And it's good to socialise.
Yeah, and the social side of it.
What do you feel after you've run?
Liberated. It's exciting.
Really good. Full of life.
Why have you taken up exercise, Janet?
Because I've got to middle age and I feel that I need to get fitter now, and there's no reason at this age why I can't.
I feel good because I feel that going consistently makes me feel better every day, every time I go. Yeah.
I run because it's helped with my confidence as well as feeling healthier, and I like running with a group of people. I find it really encouraging and fun.
I like running because it's fun and it makes me happy. I think it's like a mental kind of, what's the word? It makes you feel better to run. It like gets rid of all your energy and just, yeah, I feel better doing it, basically.
Karen, why do you run?
Because it makes me feel good, and if you could switch me off then.
The women do surveys for us to share what their experiences have been, and we've seen reductions in their blood pressure, in asthma symptoms, obviously in weight loss, but also in confidence in their bodies as well, and around their mental health as well, so improved connection within the community. So many of them feel like when they're running, which I can't do when I'm running at all, they can talk to the other women and share their concerns. I don't know about you, Natalie, but I can't do that. So there's been lots of friendships built in our community and social connections between people that wouldn't necessarily have been friends otherwise. So for us, it's been a really fantastic project that's relatively low in terms of preparation and stuff like that, and yet they've been going for 8 years now, meeting every week to run. There's normally about 8 women that run each week, and there's 169 members on their Facebook group as well.
Fantastic. Next slide, please. So we were introduced as a group that feeds tummies, which is part of what we do. We've been involved in running holiday clubs for the past 8 years. And so just to give you an idea of what that looks like, we want to create a safe, welcoming, fun environment for children who are on free school meals. Now, a lot of you will know that children access free school meals during term time, but it can be a struggle during the holidays for a lot of families to then find the resources to feed their children well. So the holiday clubs have been set up to address that issue that we have witnessed firsthand from the connections that we've got with many of the families that we work with through the Life Centre. We also heard from schools as well that this was a need that they observed. Our holiday clubs are much more, though, than just feeding tummies. We want them to be a place where children can experience a variety of activities. We have an hour's daily physical activity, and we have incredible enrichment providers who come in and do all sorts, from comedy workshops to spoken word workshops. There's so much variety and fun for the children who attend. Now, when we started, it was based in our community centre. Just 15 children, and lots of volunteers from the local community would come along and help these clubs take place. And what enabled us to do that was small pots of funding. So we were able to get the volunteers to support what we were doing. But now, what we found is over the years we've been able to gather from our experience evidence as to why this works. So we were able to present that to the government APPG, and of course over the recent years the government has responded to campaigning that we have been involved in alongside other small community groups to raise awareness of this issue, and there has been changes in government policy. So the impact that we have seen has also been researched by the DFE. And what they have seen is that there has been improved nutrition, a reduction in food insecurity, there's been less social isolation and more community bonds for children, higher levels of activity and more stimulating and enrichment. So our holiday clubs have been so much more than just feeding tummies.
Brilliant. Are we okay with the next video? I feel like we've also ruined the guys' tech life here as well as ruining the coffee breaks. I feel a bit bad. Are we all right to play the next one? Thank you. Oh, don't stop on that bit with the terrible looking building.
See if we could get some funding and start to deliver a breakfast group that was a bit different from other breakfast groups here. When they arrive, we provide them with a really nice breakfast in the morning so they can choose cereals, toast, bagels, fruit. We want the children to feel very happy when they come in and mostly to feel calm and at home. So the feel of it is more like a family breakfast. So when they've had a breakfast, we spend some time looking at the children's feelings. So we'll use different types of materials to help the children to talk about their feelings. And then each day we'll have a focus. So we might be looking at anger management for a couple of weeks, or how to make friends with other people. And we'll do activities that help the children to focus and to build their skills in those things. Throughout it,
The team will be using kind of strengths-based models, so trying to be as positive with the children as they can be. Often we have children coming here who are tearful in the morning, who are upset or angry, and so by being able to provide a bit of a cushion for that reduces the impact on the teachers and the teaching assistants in school. And for some of our children, they struggle to have their needs met at home emotionally, and so we provide a space where they can receive love and care and consistent contact with adults that can be positive towards them.
Me and Alfie have been coming here for 3 years, and I was a bit chaotic, if you can describe that. Shy. I want to speak. The only 2 words I say was please and thank you. I won't get to say nothing else.
The boys, it's helped with their development. You can see the actual change in them from the last couple of years to where they are now. There's a big improvement in their behaviour, their attitude. It's been a really good experience for them. We even attend outside activities with Breakfast Club. That's how warm and friendly and welcoming it is. It's absolutely brilliant.
That's fine, you can stop it there, that's brilliant. Because, Stuart and the 2 kids say what it's about, really.
Breakfast Club is fun, amazing and joyful. Breakfast group for me is a happy place, a calm place and a relaxed place.
If you'd like to know more about Breakfast Group or our work at the Life Centre and how to support us, please do get in touch. So our breakfast group is an opportunity for us to hang out with a small group of children each morning, and it's one of the best things that happens in my week is spending time with those children. And we've seen the impact of that over the last 8 years in terms of improving the children's nutrition, improving, the teachers tell us that it improves their attention span at school, that by giving them experiences of being around other adults, that it changes their aspirations around what they might want to do in the future, and that they have more confidence within their emotions and their ability to kind of go out into the world. We, again, had very small pot of funding to start that project, £2,500, and now it's supported by Kellogg's and by the local school and by fundraising. So it's not something that's taken a large amount of money to do, and yet it's impacted on the lives of those children, but also on the wider community as well, because as you could hear Stuart say, we don't just involve the children, but we also support families as well. And We go out to the beach or Blackpool or wherever it might be together. We go together, not us taking a trip, but we all go together. And we have lots of fun together. And in that, we build those social connections. And it meant that when COVID happened, it was easy for us to continue to support those families to pop round and do stuff on the doorstep, which was great. If we can have the flag football slide, if possible.
So we have this fantastic work that we're privileged to engage in with children. We've found out about the Breakfast Club and about the holiday clubs, which are now expanding across the whole of Salford, and we've got about 900 children that can access that. But we also involved with flag football. Now, who here has heard of flag football? Not even one person. That is fine, because I hadn't heard of it either until I went and saw the Salford Scorpions, who are pictured on the screen at the moment. Now, the idea of this was set up by a local person who was incredibly passionate about sport and making connections with people. Now, what it looks like is it's free training that's available every week to adults, and it's led by volunteers. And again, it's another project that has been enabled to happen because of small pots of funding. Now, this has been funded by Salix Homes and NHS CCG. And what that goes towards is these weekly training sessions, a venue, insurance, and this fantastic Salford pink kit. Now, it's enabled 30 adults to connect, and we can kind of track the physical fitness profile of these guys, because the first picture at the top is when they initially got together. The white kit is when in their early days, and then the Salford pink kit is more recent. They're now competing in a national competition, but it still remains a free, accessible thing for all adults. And there's normally about 18 guys who connect in with that every week. We've also been able to extend these sessions to young people, and we found that it's particularly well attended by young girls. These sessions demonstrate the positive outcome and the impact that volunteer-led sessions can have. And at these sessions that are for young people, we've had about 80 people that are part of it, but on a weekly basis we get about 20 attending. I'd love to read you some quotes. They're on the next slide. We've had so much feedback, but we've just selected a few of them so you don't get too bored. So, flag football is the highlight of my week. Without it, I wouldn't have been able to find a new sport that I would come to love, which has brought out the best version of myself. This has crossed over into my work and family life, which has changed dramatically because of this weekly activity. I thank flag football for helping me to be the best person I could be and bring a smile back to my face. Flag football gave me the push I needed to improve my health. After several health setbacks, football gave me the opportunity to get myself back on track. From football, I've been able to take part in weekly park runs and continue improving my fitness and health. Without flag football, I'd have no social life. Because of flag football, I am more socially active than I have ever been. From flag football, I've been able to take part in charity runs, social outings, and meet people with similar interests in mine. Thanks to flag football, I have a more positive outlook on life. I was quite lazy before the project got me out of the house, making new friends, and also losing weight.
So hopefully that's given you just a little overview of 4 of the projects. We could talk about the projects all day, couldn't we? So we won't, because of the coffee break, which is coming up. So we've got just a few takeaways that we thought you might want to think about going away from today.
Okay, so the first one, local people have great ideas how to reduce health inequalities. I think sometimes we can think we've got all the answers, but in fact, there are people in our communities who have fantastic ideas, as we've demonstrated through some of our projects, that we can get alongside them and draw on those passions, those interests and those skills and those knowledge.
Yep, hopefully you can see that all the projects that we've talked about started off with really small amounts of money, and you might be part of a GP practice or a CCG that has pots of money to help with health inequalities. If you have, why not consider supporting one of your local community groups, or seeing if there's a local CVS to you that might distribute some funding to support health inequalities in your area. You might find that it even changes government policy as a result, because small community groups can multiply that money big time and campaign with the difference that it makes. And for us, we've seen that go from no funding in Salford to £1.3 million a year for HAF. So,
have a think, what community groups operate around you? Because that's a good starting point, isn't it? And also, how can you see the person in context of where they are in your community? And what are the connections that they have or maybe don't have? Because our input can help to expand that, but being aware of the person in context is very important, as was mentioned in the previous talk.
Yep, I'm afraid this one's been cut off a bit, but this is just a little bit about our approach at the Life Centre, to say that we try to approach people by looking at them as functional as opposed to dysfunctional. So we base that on some work from Richard Schwartz and the internal family systems that thinks about the fact that people who've experienced trauma, and all of us have had some level of that, but often in deprived communities we know that people have experienced more. The choices that we make and the behaviours that we do, whether it's using alcohol or substance misuse, ending up obese because of overeating or not exercising or whatever it might be, often those things are functional for us because they protect us from that trauma or that pain. And so rather than seeing that as something that we just need to deal with, that issue of substance misuse, we at the Life Centre want to ask about why that is, what it does for that person in their life. And so I'm sure that's similar to what Jen was talking about in terms of being trauma informed. But that's really important to us, that we recognise that people's bodies and minds are often trying to look after them and protect them. And so we want to treat people with kindness in that way and work out what's happened that's led them to this behaviour, which might not be good for them in the long term, seeming functional in the moment.
And finally, everything is better done together. So it's not about doing things to or for, but with. Let's draw on the skills and the local knowledge and the passions of the people in our communities.
Thank you very much.
Thank you so much, Beth and Natalie. That's really inspiring to know what could be done, with such a small start, but then it kind of grows and multiplies and addresses those health inequalities. I think the things that we take for granted, like food and other things, can be a bit of a big challenge for even our children and adults alike. So it's just about thinking how we can do that better. But I wouldn't keep you long, keep you away from coffee. So there's coffee now. So that's coffee. So make sure that you do get to speak to somebody that you don't know. I think it's very important to kind of fire those ideas together. Any questions that you had for the panel or anybody else who spoke, they're going to be there. So do find them and ask your questions. And I'm sure, they'll be welcoming your ideas as well if you've got anything to share as well. We'll meet again at 11:15. So sharp 11:15. Back again, and thank you very much for the tech guys as well. When all the slides came together, I was like, what's happening here? But thank you so much for that as well. So 11:15. Thank you. Hello, everyone. Can you still hear me? So if we could just make our way back and sit back into our chairs. I hope you all had a good coffee break. I think there was plenty of choice, biscuits and fruits and stuff for our hungry tummies. I'm sure there's lunch as well, so before you ask me when lunch is, I better tell you now. Or rather, I'll keep it as a secret. So our next speaker is going to be Emma Rowe from Focus Care. So I'm not going to talk a lot about Focus Care because you're going to hear from Emma Rowe herself on what they do and why I find that, a very interesting addition to our lives as GPs or clinicians within the practice on what we can actually do to make a life change. Like Laura was talking about, you do see people change, you do see lives being changed. So without further ado, it will be Emma Rowe.
Hope that you all feel a little bit refreshed after some coffee and biscuits, and hopefully you're all in a little bit of a better mood to be receptive to what we're talking about. So I'm going to talk to you about focused care. There's been some mentions in previous talks just about focused care practitioners, and some of you have focused care in your practices. We've worked with you for years, and you'll know exactly what we are, where we've come from. Other people may have never heard of focused care, and so this is just a little bit of a background for you of what we are, where we've come from, and hopefully where we're going as well. Might help if I actually knew how to use the pointer. Oh, there we go. So also, Laura said in her early talk that you can heckle. Please don't heckle, that'll actually really put me off. So please be well behaved. So focused care, we look at poverty, complexity and engagement, and that intertwined is what we look to deal with and to be part of that intertwinedness and unpick it hopefully for some of the people that we work with. So this is a beautiful picture of Oldham where it all started, and you can see the lovely hills in the background and quite a nice place to work. The reality was a very grey porter cabin that looks a little bit different. So Hope Citadel was in primary care and Focus Care all started in primary care. I would just like to point out, when I saw this picture, I don't know how well you can see, but Laura is in that picture of people of the original group of the setup, and those pink tights are pretty impressive, Laura. So, in this picture of lots of snowmen, there is a panda somewhere. It's really, really difficult to spot, and our strapline for Focus Care is making the invisible visible. Once you spot that panda, it's really, really hard to unsee it. And so the GPs that were working in primary care in Oldham, they read papers, they saw all of the documents that said there is health inequalities in our area, but they couldn't see it, they couldn't access it. And that was where Focus Care was born, that they said, right, we need to do something to address this. Let's create something. And made their first Focus Care worker. Once they saw it, you cannot unsee it. So I don't know who's found it, but at the bottom, the panda is sat kind of on that bottom line. And once you've seen it, you literally look at it and you're just like, oh God, how did we not see that before? And that is what we're now seeing with Focused Care. You know, the growth that we've seen in the individuals that we're working with, it makes you think, how did we not ever see that that was there? And how could we ever not work with those individuals? So the typical Focus Care patient that we look for are the people that keep you awake at night. When you leave practice or you go home after your day's work and you just think, I really don't think I helped that person enough. I'm really worried about them. I don't know who to signpost them to. I don't know how I can help engage them better. Those are the people that we want to try and make you feel better about, that somebody is helping them.
people with multiple complex problems. So it's not a case of they come to you with the one issue, like there was some talk earlier about they come with a list of 6 issues. They will often be a mix of medical and social. And if you look at just one of those in isolation, so you just deal with the medical issues or you just deal with the social issues, then you'll never achieve decent progress with that individual. So multiple complexity, often really chaotic individuals or families. The ones that are over-attending primary and secondary care, so the ones that are calling every day, they're coming in multiple times a week, and no matter what you do, no matter who they speak to, no matter who you refer them to, you are just not sorting their problems for them and you're not making their lives better. And then the flip side, so making the invisible visible, that disengagement. They might be registered on your GP surgery. You might even know that they have multiple complex health issues, comorbidities. They're on your QOF register, but you never see them. You might send letters out, they'll never come in. They're the ones that Laura scoops up every year when she goes door knocking, but you just can't access them. Or you make a referral for them that they've actually kind of come to a surgery and said, I've got this issue. You make that referral, but they never engage in that service, and you don't know what reasons are behind that. So that is our typical patient that we aim for. We pick the most complicated. So this is the FitBus model. So it looks at what health inequalities are and breaks that down, and it uses a term that's coined in paediatrics, so failure to thrive. If you've got an infant that's small, they're not gaining weight, they're not achieving their milestones, they're classed as failure to thrive. And when you translate that to adults in our community, we see lots of adults that are failure to thrive. They're not achieving in life with multiple issues. And that failure to thrive is multiplied by their barriers to universal services. So there might be universal services that are in place in their area and mainstream healthcare, but for one reason or another, they have barriers that are blocking their access to it. And then that's just exacerbated by the social determinants that they face on a day-to-day basis. So that is our FitBus. So what we do with people that are experiencing this failure to thrive, we go out and we find them. We again look for the most difficult and we want to make them visible. We want to spend more time with them than the time that a GP has, because that 10 to 13 minutes that you get, we want to be able to engage with them over a long period of time and work through with them in that change. So passion led us all here. I think that any focused care practitioner or anyone that works for focused care has a massive, massive passion. And probably everybody in this room has that passion as well, because otherwise you wouldn't be here. Let's face it, it's much easier to work in leafy suburbs where you've got more opportunities and people engage. But what you get reward from the people that you work with and the individuals that we deal with focused care drives our passion to carry on working with them. So we work in, Laura had this slide up before, we work in the bottom 20% of deprivation in general. So looking at the deprivation score of a 1 or a 2. The really interesting surgeries are sometimes surgeries that might be a 4 or a 5 on the deprivation score. And that's because they're massively skewed by areas around them. So we've had inquiries from surgeries, and when you look on the data, the government data says that they're in an area of or half a mile away is a 7 or an 8, but their tiny little pocket that they're sat in the middle is a 2. And so the services that are around those areas are actually almost much worse than an area of wide deprivation. So they're really, really interesting pockets to look at as well. So we look to work with the most vulnerable in the most deprived, and we highlight that gap between the social and the medical. We are a complementary role. We don't want to replace existing roles. If something is being done and it's being done well, then fantastic. We don't want to replace things. We want to add to them, and we want to make things better. So focused care sits alongside a number of other roles. They work within the multidisciplinary team, and they work within their GP practices, and they're really, really integrated in the practices as well. We found from the very early days that the bottom 20% of deprivation actually financially and time-wise takes up 80% of your time and your finances. So if you invest well and you invest early in that bottom 20%, the change can be massive to see. And our focused care practitioners know their areas really well. They know their communities well. They know their GPs well. They know their services. And that's really, really important as well. So when our initial focused care worker went out and we started doing initial assessments with people, these were the key themes that we found. Often there were a number of themes that came up. It wasn't just one of them. If it was one of them and an individual engaged in, say, a referral to a smoking cessation clinic, fantastic. If they've got a number of those, you already start to just build those barriers to be able to engage, and they might not take up that option of a referral to one service. We see these themes over and over again. They're very, very common in amongst all of the people that we deal with. The outcomes that we've seen from working with individuals in focused care have been phenomenal. Like Laura said, you know, when you look at the data, it is unbelievable, the change that people can make. And if you really engage somebody and you work with them at that level of complexity, they often do want to change, and we involve them in that model of change that they're willing to make for themselves. So you see improved mental health, reduced PHQ-9 scores, reduced debt or a debt management plan in place that they feel more able to deal with. Benefits issues are sorted so they get a further entitlement to benefits, or they don't have any concerns about their benefits going forward. New tenancies that are supported, or families that are coming out of temporary accommodation and they're more stable and they've got a base for their family that they can start to build on and grow. People that were previously unemployed have returned to employment, and the reduced risk of physical abuse. And then health outcomes, you see reduction in alcohol, reduction in stimulants, opioids, cannabis use, reduction in or completely stopping smoking, and then the uptake in the screening programs that are national that previously they wouldn't have engaged with potentially. They've got trust in that professional, they've got trust in a focused care worker that then builds them back into the mainstream system and says, come on, let's go to the GP, let's get you screening, because that's really important as well. Yes, we've dealt with your mental health issues, yes, we've looked at your housing, yes, we've looked at the fact that you've not had electricity for the last 3 months, and you're moving forward and you're progressing. What's really important is we look at the future and we look at your health and make sure that you're in the best health possible. So let's go and have your bowel screening. So there is a case study for a patient that had uncontrolled diabetes and schizophrenia, was very, very socially isolated, not integrated within the community, and had missed a number of healthcare appointments. Had a really poor diet, heavy smoker, heavy intake of alcohol, and often didn't take his schizophrenia medications regularly either. So he was referred by a GP to a focused care practitioner, and they started to work with him. He'd missed a endoscopy appointment that was really important for him to go to, but he hadn't gone because he couldn't cope without drinking alcohol. So they arranged the appointment for early in the morning. The practitioner went along with him, and he went to that appointment. And just from that initial appointment, that started to build trust, and then worked with the practitioner to say, actually, I will look at my mental health issues, and I probably do understand that it's important to look at that. And the focused care practitioner helped him access counselling services to help with his schizophrenia. And that was quite an interesting relationship that they built, that then they could start to look at the other health implications, so looking at the long-term management of the diabetes as well. So who are these wonderful people that we get to that we get to do this job? They are a very special cohort of people, and they have common themes. They're a little bit nosy. They're very, very kind, and they are very determined, and they've all got a really, really strong sense of social justice. They want to make a difference, and they want to see a difference in individuals' lives, and they will work tirelessly to see that. So we hire really experienced individuals. They've often got 8 years plus of experience, and they sometimes come from being qualified social workers, qualified nurses, probation background, working on the front line, and we want them to carry on working on the front line. They don't come to us for an easy life. It's not a step down. It's very, very much frontline work, and they know that they're going to carry on that frontline work. They've often got a little bit of annoyance with the system, so they've worked in systems where they've wanted to engage, or they've wanted to take a next step, or they've had an idea, and there's been barrier after barrier after barrier, and we give them a little bit of freedom with some clinical governance to keep them safe and keep us safe, keep the patients safe, to say, actually, you've got a bit more freedom. You can bend the rules a little bit, and you can do something that maybe another healthcare worker wouldn't be able to do, as long as we can keep you safe and it's productive and it's a therapeutic relationship. We give them mandatory training, they have ongoing clinical governance, and they have safeguarding level 3 as a baseline. We have lots of teaching sessions for all of our practitioners, and because of their wealth of backgrounds, they all learn from each other essentially. We have a really, really good supervision model that is a 3-monthly rolling programme, and so they have a one-to-one with hub leaders 1 month, then they have a clinical supervision a following month, and then they have a whole hub lead group the following month. And that keeps them safe. The complexity that they hold and that risk that they hold as practitioners is really, really heavy. And when Jen was talking earlier about compassion and about somebody to kind of have that overflow of your bowl, we really need to provide that for our practitioners as well. There was a recent study from the Royal College of GPs that looked at social prescribers and the fact that in the next 12 months, a survey that they'd done said that 1 in 3 of them were going to resign. And the key themes that came from that were around their HR, their supervision, their ability to be integrated within the GP or the service that they were involved in. And that's a really, really scary thought. If we think that 1 in 3 of our social prescribers are going to resign in the next 12 months, we need to make sure that we're supporting them and we're going forward in the right way in terms of the complexity and the risk that we're asking them to hold and carry. We have at Focus Care a raising awareness or a significant event. And that is a way that any practitioner, if they've got worries, concerns, something's gone wrong, they submit that and that gets picked up by senior management. From that, we can see key themes that hopefully we can try and address and change. We can address any issues, and we're really, really keen to learn from anything that's happened as well. It gives a sense of accountability and just keeps that clinical governance in place. So we are currently, across Greater Manchester, we have 37 Focus Care practitioners and we have 3 Focus Care assistants. We have 2 Focus Care practitioners who are for homeless families, who are over at the back. There's the lovely Angie and Matt. Give us a wave. They are free today to talk to anybody that wants to talk to them about the Focus Care practitioners for homeless families. And that's on a slightly different model as opposed to being based out of GP surgeries. They work alongside Oldham Council and the housing. So a little bit of a different branch that we've got that we've seen some fantastic results. But please go over and speak to them later today and they will fill you in on all of that as well. We have coverage across Oldham, Rochdale, Central Manchester and North Manchester. And in the last year, we've had 3,171 referrals into Focus Care. Of that, they have had 2,313 accepted onto the caseload. So that difference of what's accepted is often either an individual has been able to access a service and they've engaged well and the need isn't there for Focus Care practitioner in terms of complexity, or that case has been referred on to a social prescriber because actually we know that they will engage and it might only have 1 or 2 issues that a social prescriber is able to deal with as opposed to that high level of complexity and disengagement. So how it all fits with primary care and PCNs and all of the lovely acronyms. So my background is secondary and tertiary care, and the NHS just love letters, don't they? They love making it really difficult for anyone that's outside of our world to find it really difficult to understand what everything is. And I love that primary care is no different. So our practitioners sit under the R's role and they sit under the social prescribing band 5 that we claim, and we're really, really fortunate as a organisation to have philanthropic funding from the Oglesby Charitable Trust that enables us to employ our practitioners at a higher level, that have got that higher level of experience and hold that risk as well. And so we employ them at a band 6 level, and we do that top-up funding. That is something that hopefully going forward we can show a model that actually we need to make this go forward nationally, that it is at a band 6 level, and that we can demonstrate that importance of it being that complexity. The IIF funding for the social prescribing referrals, obviously every PCN has to now hit the target for. Focused care does come under that IIF social prescribing code, and our practitioners can put that code onto EMIS as well for the patients that they deal with. So looking at how it actually matters for you as a practice, primary, secondary, tertiary care, the reduction in inappropriate A&E attendances has been shown to be absolutely huge from all of the work that we've done and the engagement that we've had with our patients. And then these are some of the things that have come from individuals that we've worked with that I think, you know, when it comes back down to that person level of the individuals that we deal with, these are the things that they said that just mean the world to the practitioners and to us as an organisation, that you know that you've made difference after difference to an individual or a family. So going forward, our future planning, we currently are being independently evaluated by Cambridge University to give us some quantitative data on what we're doing. We know that it's fantastic, and we want that to be shown essentially in something that we can really demonstrate and shout about. We want to continue to give high quality care and service delivery in the areas that we're already in, and continue to build those links around Greater Manchester as well. There is some work going on around homeless family, focused care practitioner growth, which we can speak to Angie and Matt about. I'm sure they'll fill you in on all of that. And also potential growth along the M62 corridor when we look at deprivation health and what we can potentially start to make a difference for. If we've got the model right in Greater Manchester, it would be lovely to see that replicated in other cities in the north as well. Any questions from anybody? This is where you all sit silently and don't give me a grilling. If there's no questions, I think my leave-in point would just be that if you've got practitioners that work with you, embrace them in your practice and care for them, because they want to make a difference to your patients and to you as healthcare professionals. So really, really do embrace them, look after them and make them part of your practice, because you will absolutely feel the benefit of it. Thank you very much.
Thank you so much, Emma, and thank you very much for the Focus Care team and the work that you do. And it'll be really, it'll be exciting to see you all kind of spread across and M62 and all across England. Of course, there'll be definitely a need for everywhere, wherever there's health inequalities that exist. So that leads us on to the next session, and that's from our dentists. Yes, I'm sure that we all brush twice a day, all of us? Yes, today, yes. Okay. So one fun fact about, I'm a respiratory physician or GP with a respiratory interest. Did you know that actually if you have good oral care, it prevents you from getting pneumonias? Yeah? And if you actually do good oral care in hospital when they're admitted, you actually prevent them from getting hospital-acquired pneumonias as well. Simple things that could be done, but I'm sure the trauma-informed dentist, so that's what kind of interests me, because we all talk about trauma-informed care a lot, because if somebody goes through the trauma that they go through, the people that we talk about have got enormous trauma in all sorts of shapes and sizes, and the way they interact, the way they see power, the way they see the consultation room, the way they see us could be, could be kind of, it's all very blurry. And I think it's very important to understand, where they're coming from to be to be able to think about how you can help them. So when we've got these two dentists who are trauma-informed, so I've got Christina Wall, and she is a dentist in a community dental clinic, and she provides trauma-informed general dentistry to many vulnerable groups in the community, including vulnerable women and those suffering with homelessness and domestic abuse. So dentistry beyond the teeth. So that's really fascinating for me. And the next speaker along with her would be Dr. Ben Atkins, and he's the clinical director of Revive Dental Care. And Dr. Ben is a trustee of the Oral Health Foundation, and together with Christina, they will showcase the trauma-informed dentistry work that they're doing in Manchester and Plymouth. So we can welcome them now.
Thank you, and thank you for including dentistry and mouths in your day today. It's a real honour to be here, and you've no idea the amount of times I've attended kind of some training days like this, and they talk about multidisciplinary care, and teeth are nowhere to be seen, or mouths are nowhere to be seen. So I think it's so important, and to steal, Raj, your analogy from earlier about if you have a problem with your boiler, you call your dentist, but it's still your house. I think probably, unfortunately, a lot of GPs think their mouths are also your house too, and there's so much scope for us to work together for our patients. So I'm Christina, as you said, I'm a general dentist and I work in Plymouth. I'd like to talk to you today about why oral health is important, especially to the group of people that we're treating, why dentists need to be trauma-informed, and what I feel that looks like. So as we can see here, this definition of oral health encompasses so much more than just toothache and teeth and gums. It also includes the importance of being able to convey a range of facial expressions and emotions with confidence, and I think that's a really key word here. It won't surprise anyone that oral diseases are negatively associated with health-related quality of life, but also psychosocial factors play a huge part in this. And in a study it was in Scottish prisoners, I believe, their oral appearance really affected their self-esteem and their ability to interact with other people. And from the patients that I see and treat, the shame and the fear of judgment that they feel is so much more of an issue for them sometimes than the toothache and the pain. I've had sort of a young 20-year-old man who has retained his upper 4 front teeth for 2 years despite suffering recurrent abscesses, pain every day with them, because he could have them out, but there was no option for him to have them replaced in the system we have at the moment in Plymouth. And he'd live with that because he didn't want them out. He didn't want to have no front teeth. And I think, who can blame him, really, when we think that? So we all make judgments about how people look, whether we then go on to challenge them or not. This gentleman is under 50, and how might people think if he went for a job interview or something like that? And then, it's so much more than teeth. It affects the whole of someone's face, how they look and how they present and feel about themselves. And again, I expect, sadly, many of you are used to seeing patients that look quite like this woman. Again, this lady is under 40. And, she sat there and said this in the chair after she'd had her dentures fitted, and I was sort of like, quick, let me get a pen and write this down because this is amazing. And I'm very grateful to these patients for letting me share their photos today. So as I said, I'm from Plymouth, and I'm sure like most towns in the UK, and certainly Manchester, we have this map of deprivation across the city. Some of the areas in Plymouth are in the sort of 2% highest deprivation, and I work smack bang in the middle of that dark red area. So I work with people who've suffered homelessness, addiction, mental illness, domestic abuse. I work with women who've had children removed, and often a mixture of all of these issues. In the company that I work for, we also have a looked after children's clinic and an asylum seekers and refugee clinic. So why do dentists need to be trauma informed? And I expect most people can answer that, but there's sort of two factors, and one is what's happened to that person in their life and maybe what dentistry and healthcare they've experienced. So many of the patients that I see have suffered an adverse childhood experience of some sort, whether that's neglect or abuse or a mixture. And sadly, many have suffered also sexual abuse, either as children or as adults, or quite commonly both, or also domestic abuse. And there's a lot of similarities, unfortunately, between dentistry and what somebody may have experienced. They're having to come in, they're having to lie down, they're having to accept treatment, they're having to have things put in their mouths, they're frightened, they may not feel that they can say stop. And it can trigger many people back to what they have experienced before. Another, I think, really traumatic experience for people is what they may have experienced before in terms of dentistry. So dentists not stopping when they're in pain. When they were children, I think dentists used to use nitrous oxide, so laughing gas, anaesthesia, probably quite a long time ago, my parents' generation. And there's a group of people that just say they remember the mask coming and being put on their face, and then they don't remember anything. And we don't do that anymore, or some dentists do, but it's not routine. But there'll be people that remember that, and sort of issues with people gagging because of what they may have experienced. And also this judgment, and that will be common across all of healthcare, but certainly people feel judged for even wanting to have a nice smile. They feel they don't deserve one, and they feel like dentists think they don't deserve one, and that can be as powerful as well. So what does trauma-informed dentistry involve? So I think it's certainly not a tick box. Currently, there's no training course or certificate that says, yes, I'm a trauma-informed dentist. I think it's a journey for somebody, and also the organisation that I work with. I think it's really important for me to point out here that just because some dentists don't say they're trauma-informed, it does not mean that they're not working in a trauma-informed way. There's many amazing dentists that work in general practice. I think if you like treating patients who are nervous or phobic, you will be working in a trauma-informed way in the special care dentistry services and community dental services. Before doing some of the work that I've done with the communities I work in, I haven't even heard of trauma-informed. And it was only when some of the groups that I started working with started calling me trauma-informed, I thought I'd better do some research on what this is and learned more about the approach. And I think this is probably replicated in medicine as well. I imagine it's very similar. I think I learn all the time, both from the patients I work with and from community organisations. I think it's fundamentally strengths-based because of what's happened to some of these patients. The reaction that they're having to dentistry is completely normal. The fact that they've engaged with me either by phone or they've turned up to an appointment shows how much courage that they have, and that they can overcome the fear they have about dentistry, or enough to be able to have the treatment that they want. I think it's really important to say that the survivor voice or the lived experience is really paramount, and I wish I used that more than I do, and I think that's something I really want to develop. Moving on to the survivor voice, Bristol are running a really interesting collaborative study at the moment based around survivors of childhood sex abuse, which is led by Neely, and I'm lucky enough to be involved with that. I think that will be really exciting. And one of the contributors to that is a lady called Sophie Olsen, who's the founder of the Flying Child Project. And she's done some amazing work, and she has taken time to liaise and talk to me about dentistry. And I think, based back to what I said earlier, some of these quotes that she has written in her blog really describe some of the challenges that people have with dentistry. So what do I feel that trauma-informed dentistry looks like? So I think it starts even before the appointment. I work a lot with social prescribers in Plymouth, support organisations, drug and rehab organisations, and volunteers at homeless hostels and places like that. And often they are my first contact, not the patient, because of factors that we all know. And building and maintaining a good organisation with those with those groups is really important. You know, that's where you get your feedback from, because you may not necessarily get it from the patient at the time that you're seeing them. It's really important to promote a positive attitude to dentistry with those groups, because that filters out. My organisation that I work with has given sort of oral health ambassador training to many of the support workers that we work with, because they're seeing the patients so much more than I do, can just keep reinforcing that message. And if you're terrified when you come to a dental appointment, you know, you may not remember all of the things that someone's told you about how to brush your teeth. And as I mentioned, it works with the two-way learning. I think the flexibility of the service is really important. COVID actually really taught me a lot about phone conversations before, because that's not something I necessarily routinely did, and I do now. Many of my patients are terrified. Getting them in the room, they may not sit in the chair, is the first part. I mean, there's a lot of talking that happens. But I think what's interesting is once somebody is used to coming in and seeing me, they trust me, and we've done some things, is that then the appointments don't really take that much longer than someone who isn't scared of dentistry. I struggle massively with arguing and understanding attendance policy with my organisation. I think the default is 2 strikes and you're out, which doesn't work with the groups of people that I see. But I think getting the line right is difficult, so I'm always open to suggestions. Communication is paramount. I think I've also referenced the amazing Karen Treisman here, is that you don't have to be a therapist to be therapeutic, and you know, it's so important. It applies to all staff members. You know, and I know I won't need to really talk about this too much. I think I would like to emphasise that I'm really open to talking about mental health with my patients. If somebody is coming in, it's not unusual for a course of treatment to last up to 6 months and be seeing the patient every 2 or 3 weeks, and that appointment could be half an hour or longer. So you really build a relationship with that patient, and they can really start to open up to you about things that maybe they don't quite get around to when they see their GP or somebody else. And that can be, you know, I've had disclosures of previous sexual abuse halfway through, and then you can signpost for that, and it can be really important. And as I said before, it's really normal to want a nice smile. That's not something somebody should be embarrassed to ask for. So during the appointment, I think I really emphasise that each patient, it's sort of a problem-solving approach to what they need from me, because everybody is so different. What is trauma-informed to somebody who's suffered an awful lot of judgment and a dentist that didn't stop may be very different to trauma-informed for somebody who's previously suffered sexual abuse. And it's problem-solving with each patient. So, I mean, we always take the time the patient will need, try and explain everything to the patient, and also agree a stop signal. And generally that's put your hand up, but some people may not feel able to do that. Sometimes it's having their advocate in the room with them and squeezing their hand, and that person will tell me I need to stop. And I always empower my nurse or any support worker who's in surgery to do that. There are some really great resources out there for trauma-informed dentistry. So Dental Fear Central has a piece on it, and also Wellbeing Form. And it can be really helpful if you are supporting someone to go to a dentist who maybe does this a little bit less. These things can be really helpful. These specific resources from Victim Focus talk about trauma-informed dentistry people that have suffered sexual abuse, and they're really helpful. I've written a piece along with one of a support worker that I work with, for the Shame in Medicine project, discussing shame-sensitive dentistry in a bit more detail. And also Luna, who runs the Shame in Medicine project, has recently published an article on why trauma-informed must be shame-sensitive, which I think is really brilliant. So I think when the challenges with trauma-informed dentistry is that there is problems with NHS dentistry at the moment. I think it's been all over the news and the papers, and there is a lack of access to dentistry generally. I think you can support your dentists and commissioning teams to develop models that are better suited for this, and Ben is going to come on and talk more about this in just a second. As has been pointed out, we need trauma-informed organisations, not just the dentist. Wellbeing is really important. I like the model with the bowls running out the water. I personally often feel quite squeezed as the trauma-informed clinician, in that you have the pressure from the patients and then also from your organisation. So we need to look after each other. So I've popped all my resources on there, but I'll hand over to Ben now, who's going to talk more about his experiences of this.
There we go. Fantastic. Hi, my name's Ben Atkins. Until about 3 years ago, I owned Revive Dental Care, who is a practice in sunny Salford. Oh, that's me. I keep bees as well. So until yesterday, we had a fire and it burnt everything down. But that's life. That's where we are. My big passion, I suppose, to give you an idea about me, I had 150 staff. I bought my first practice when I was 24. We had 11 practices. I ran the out-of-hours from Merseyside, Cheshire and Greater Manchester. So if your patients had toothache, they saw one of my clinicians, probably Christmas Day. I got a phone call Christmas Day, the usual, difficult patients, and we've all had those difficult clinical journeys through our lives. So what I wanted to do was quickly show you this video here and then continue the lecture, if that's okay, if we're going to manage to do that.
My name is Abdul and I'm 24.
Hi, my name is Annie and I'm 35 years of age.
My name is Tony, my age is now 57. And I'm basically on the streets.
Can you stick your tongue out?
How do you reach the hard to reach? For dentist Ben Atkins and his team in Manchester, you go to them.
Any medical problems that we should be aware of?
I'm on methadone.
Okay. So what are your thoughts on them?
I want them out.
We're in a tiny side room at a drop-in centre for homeless people.
Oh, you got a bit of a hole in it?
Yeah, hole.
We're going out to these sites, and we go to a lot of different sites we go to. I mean, they're shocked we've come to them. You're coming into their environment. We're going to somewhere that they feel safe.
Do you have a contact number at all?
No.
The trick is not just to sign people like Tony up, but then to persuade them to come to the surgery. Tony has lived on the streets for much of his life. He's having his teeth properly cleaned for the first time in years.
It's like when you smile, people look at your teeth and they see yellow or whatever, where hopefully now you'll see white.
A recent study by the charity Groundswell showed 7% of homeless people had no teeth, 15% had pulled out their own teeth, and more than a quarter hadn't been to the dentist for 5 years. Tony's teeth are done and he's happy. But not everyone is so lucky.
On a scale of 1 to 10, it's about 8 out of 10. Really, really painful.
9, 10, 11, 12, 13 teeth at the top there. They're all rotted to the stumps, haven't they?
Yeah.
Must be a lot of pain.
I take methadone. That doesn't help, but when you've got teeth problems and that, because it rots your teeth.
Ben's outreach dentistry is funded by NHS England and is believed to be the only project of its kind in the country.
You've seen some examples of today of what I would call Dickensian dentistry, really. There must have been some pain in that journey to get those teeth to that stage. In a rich society like our country, not to be able to care for these people is wrong.
Melissa will need 21 of her teeth taking out as Ben continues his mission to reach the hard to reach. Graham Satchell, BBC News, Manchester.
Is that okay? See you later.
So we ran the out of hours, as I said, and that contract started in about 2009. And we noticed that one of our sites was inundated with homeless patients. We happened to be in the same building as the homeless clinic in Ancoats. And so it was obvious that was going to happen, I suppose. But an idiot like a dentist, like me, didn't think of that. So we went to our commissioning team in GM, and they were brilliant. Lindsay Bowes and the team there said, look, what do you need to set a clinic up just for half a day a week to try deal with this population. And they gave us £50,000, which in a dental budget, majority of my practices are well over £1 million. It was an absolute drop in the ocean, but it was a start. And with the team there, they were absolutely amazing. So we evolved that service, and we struggled to get people to come to see us, which you guys, I'm sure you've got a couple of patients who you'd like to see me to see tomorrow, because you'll have that experience. But connecting the dots and connecting systems, especially when we're already in a system, we talked before about the mouth has been taken out of the body at the moment, and we've been put onto one side, and general practice excludes dentists at the moment. It doesn't. There are some amazing projects. We are developing and getting a relationship back again, but it would be really interesting to know if any of you guys knew how to get an NHS dentist. No? I'm guessing no, because most people don't at the moment because of the newspapers and things. But how do you get one of your patients who's in acute pain to see a dentist? And that's a real journey in itself. We've had difficulties with my dental practices actually getting GPs to work with us. We've had instances where some medical practice is absolutely amazing, really, really helped. Others, the practice manager wanted to charge us for advertising NHS services. So there are different areas that we work with, and it's interesting journeys. Our service really evolved, so we were working closely with all the shelters, and it was my team that went out. I never did. Well, I went out a couple of times, but you've got to use different people. My team were amazing at it. The key people in my whole profession, my whole business, were my receptionists, my nurses, and to be fair, keep me way out of it. I should be in the surgery dealing with the patients and actually doing trauma-informed dentistry, as we've talked about, not having to phone practices up and trying to chase patients up. So we made sure our clinic was on the same day as the methadone clinic downstairs, so we were full with patients. We managed our FTAs because we had a process for that, and everything really worked well. Suddenly, those patients disappeared because the methadone clinic changed days. So we were struggling to get patients into our clinic. We changed that, and we put some really good processes in place. Now, what I really wanted to talk about today is where we've got to now, and the ability to engage with a discussion point on where you need to be, or where we need to be as a society, and how we can link in together. So what I'm currently, every time I do a presentation, this usually takes about an hour and a half, with strategies in general practice, how you can get practices to engage, use their money as a population management tool, and that sort of thing. But what I'm working on at the moment is a project that enables a charity in Salford, which is amazing, by the way, to come to us and say, we've got an idea, we need a dentist, how can we signpost in? Where do we get? So we don't have to keep reinventing the wheel. We're working with over in Leeds. We've now managed to get flex in our general practice contracts. So you get 10% of a couple of practices in Leeds who now totally focus on the homeless. And they've taken our model that we did in Ancoats and now work over in Leeds doing that. But getting commissioners, Public Health England and HEE to line up in the same direction, there's always one cog that drops out, and is a real challenge. So I'd love your input on how we could engage with your unique patients and deal with that. So if you go on to @DentalBen, that's my Instagram page, you can get direct contact with me for later on that. So you've got multiple different patients who we used to see. 3 different groups. One, some patients simply didn't want to see me. They didn't. But our job for there was signposting. We're there when you need us as a choice, not me being the all-knowing dentist that I know how to treat your patients, because I don't know the chaotic lives. But my whole team was, we're here for you, and if that signposting message is critical to who we are. We've got some patients who've been through the homeless journey, and they need to get out the other side to restore the smile that is so, so valuable, and we're here for that. So my job as a clinician is basically, and some people just want to come and have a chat and have their teeth cleaned. Did you see his smile after he just had his teeth cleaned? Which took, 5 minutes? And it gave him such confidence, and a smile, it's nothing to me, but to him, so it's me understanding what that patient wants, and my team understanding what that patient wants, and us simply giving it. But engaging that, it built such a community, and then you got advocates, and it really snowballed. Especially the work, if you need any information on dentistry, look at the Groundswell project. They did an amazing project in London. So by engaging the patients, we got a lot of patients to complete their treatment, and it was a really successful journey. Some didn't, but they came back later on. They knew where we were. So realistically, it's a really short 2-minute thing, but dentistry is really complicated. It's not really, we just do teeth, but it's finding the patients. Dentistry is really simple if you give your time for your patients and listen to people. I don't think I'm going to talk much more. I think that's about me. So there we go. Thank you.
Are there any questions for us that anyone has about, could be about dentistry in general or trauma-informed dentistry? No. Well, thank you.
Thank you.
And do come and talk to us at the end if you'd like to.
You were legging it too quickly there.
Run away.
I work for the social prescribing team in Oldham, and this is quite a big barrier for us at the moment. It's just getting spaces within surgeries as well, which I know is not just an Oldham issue, it's across the board. I was just wondering if you had sort of any tips for that really, because we work with people for quite a while to engage them and get them involved in services, and then we get them to that point where they're like, yes, we really want to do it, but then we can't get them in, or so I was just wondering if you had any tips or advice or anything, or if you know of anything that's up and coming or whatever.
I might let Ben answer that from the Manchester side.
No
yeah.
No,
I think it's...
For me, the people that control dentistry are the dental practice managers. So speak to the practice managers in those locations. There's not going to be that many patients, is there? You know, if I said I could give you 50 slots, that would probably give you quite a good run at it until you've got it. That's not many patients. Or the people to contact is probably the local dental committee, LDC. You've got my email, and you can deal with it. I can help out and try and find that journey. Because for me, it was the problem having the patients turn up. Yeah. It was for you having a place to take the patients to, and you'll get those patients because they've got a relationship with you. I don't want my team going out to the shelters, the Samaritans, to actually do the marketing. I want my team in the surgery, and you manage the patients for me. That symbiotic journey means I can get your patients into a general, normal practice. We don't need to reinvent the wheels here, just signposting and conversation. So my biggest advice is get a list of all the practices, find out who are the practice managers, and they run it. Ignore the dentist.
Yeah, and in terms of, were you finding you're facing barriers to coming into the dental surgeries as well? Was that?
Yeah, so there's so I'll do a lot of work with him around, it's all right, you go, you know, and I'll get them to the point where they'll actually go, yeah. And like you said before, I get it, on the day they might not turn up, and then it's like, oh. But it's, yeah, getting a space in the first place is one of those barriers, but then I suppose the other side of it is that understanding as well that they might not, I might turn up the first time, or I might, you know, try and pick them up, but actually they're not answering the door to me even though I know they're there, but I will get them there, so it's that two-sided. But at the moment in Oldham, it's just actually getting a space, to be honest. Yeah. Just can't get an NHS
I think the other factor you could look at is kind of your community dental services, and some places will have a non-professional referral for that, especially if you can write about social barriers that they face if you're not getting any luck with your general dental practitioner, because sadly the dentist won't be paid anything if the patient doesn't turn up, so it's really difficult where there's we work on quite different models. So I'm a salaried dentist, so I do get paid if my patient doesn't turn up, which means I can be a bit more flexible if you've got somebody who misses a lot of the time. Thank you. Any other questions? Fab. Thank you. Well, my email address is on the slides, but if anyone wants it at the end, do come and ask.
Thank you.
Thank you so much, Ben and Christina. Thank you. I think that opens the doors and probably eyes for us into the world of dentistry and how trauma-informed or the way we work. And I think we need to start thinking as GPs or clinicians that oral care is equally important. So it's not, I think it's where it's the someone else's problem becomes very hard, because that someone else's problem never gets fixed. And you work with people who use smokeless tobacco a lot, and then that causes a lot of problems. And how do you address that? And you can have innovative ideas about dentists, creating a room for them to come and work within the practice. But I think it's just about opening our eyes and making sure that we do look into our patients' teeth as well, because that informs you a lot about medical problems as well. And I think working together will be great on that. So thank you so much again, Christina and Ben. That was really good. Thank you. So the next we have Charles. Yes, he's here. Yes. So Charles Kokuda is our next speaker, and he's the Chief Officer at the Caribbean and African Health Network. And he works to bring equity and fairness across a range of important things, mainly health and well-being issues for people of the Caribbean and African diaspora. And his work influences research, policy, practice agenda at local, regional, and even national level. So we're really looking forward to hearing you, Charles. So please welcome Charles Kokuda.
Good afternoon, everyone, and thanks for the kind invitation. I have my clock here because when we sometimes stand behind the pulpit, we, go over time. So as I've been introduced, Charles Kokuda is my name. My day job, or what takes quite a lot of my time, is the work I do with the Caribbean African Health Network. I have other hats on, working across the city region and at national level as well. So I'll be telling you a bit about what we do and some of what we found as well. Great, so CAN, came about 5 years ago. It was on the back of our chair, Dr. Faye Bruce's PhD, that was looking at cardiovascular disease and why Caribbean African people tend to have poorer outcomes. And some of these data have been there for a long, long time. So more recently, what we say is COVID hasn't taught us anything new. Yes, it's shown a light on some of the key issues, but it's given us a real opportunity to be involved in some of the discussions and conversations. And so for us, the vision is to eradicate health inequalities and wider disparities for Caribbean African people within a generation. And back in 2017, that was just about the start of devolution for Greater Manchester. We know from Friday, it's the ICSs. So then the more she ran her focus groups, we were asking what she was going to do with the data, because they get consulted and don't hear anything back. And so, 10 people came together and set up the kick. And for us, really, that mission is ensuring that we feed in at a strategic level, because there are lots of Black-led organizations that will be doing various pieces of work, running for, peer support groups and frontline grassroots stuff. But where the gap is when it comes to policy and influencing that. I won't go through this, and you can't read the text font size. But for us, really, objectives is all about collaboration. So whilst we health and well-being, we're also very conscious of the wider social determinants of health. And as many of you know, Michael Marmot and his work on, health inequalities and the Marmot City region. So yes, it's looking at cross sectors, looking at how we work with other, voluntary sector organizations and support them and try and explore partnership, but also other sectors, how we able to take that lived experience into those spaces, and then also championing the assets within our community. So one of the unique selling points, and it's great to see you this year, because she's been there right from the start, is making sure we championing the assets within our community. And one of our USPs is access to Black clinicians up and down the country. And since the start of the pandemic, from the 2nd of May, every Saturday morning, we'll have a Caribbean or African clinician who will present to the community on Zoom, live stream to YouTube and Facebook, and then take questions vaccines as a way of helping ourselves to do for self what we can, because we can't depend on the public purse for everything. So for us, championing those assets are really important. And why we were set up and what's the problem we're trying to address, it's about that poor access. So quite recently, with Core 20+5 and the other national initiatives that talk of equitable access, that's so important. But whether it's language, whether it's, historic issues that prevent people from presenting early, those are some of the things we're seeking to tackle. And then the lack of trust, which we found during our work with the vaccines, was the biggest barrier. People could not trust the fact, and we say all the time, various meetings with senior government ministers and even the Prime Minister, they couldn't just get their head around why we have vaccine is free and people, from Black and Asian minority ethnic communities didn't want to have that. But we knew about the hesitancy and the lack of trust way before that. Also poor engagement, and the last clinicians that presented talking about hard to reach. There's no hard to reach community. It's usually the model of engagement that doesn't work, and it needs to be flipped on its head. So for us and some of the work we've done, so long as we get the messaging and we come up with a model, and we have a model that has worked. So right from, HIV, testing in churches on Sunday, recruiting organ donors in church on Sunday, we've done it. Health screening on Sunday in church, we've done that, and, referring people on. So it's the model of engagement that doesn't work. But usually, other sectors don't want to invest in community engagement and research as well. And then inadequate knowledge of some of those issues that particular impact on ethnic minorities. So, early this year in the UK, for the first time, a drug was approved for people living with sickle cell. In mainland Europe, they've had medication for years, but for the first time, in the UK, the medication was approved on the NHS, and the whole issue around commissioning and all that, we can go into it. For some of us, it's about making sure we chip in our way and flagging up some of those key issues, about those particular conditions. Every day in the NHS, a Black woman will undergo fibroid surgery. But we're not investing a lot into prevention. And that is why for some people within our community, discovering a vaccine for COVID, whereas HIV for 20, 30 years, there wasn't medication and people couldn't afford overseas. They didn't want to trust that this was meant for them. And then also the bias in the system. So whether it's institutional, racism, structural, it is with us, and for us, when we talk about that, it's not pointing fingers at individuals, but it's more about looking at the structures and the systems that tend to exclude people. So for us, the health streams, we tend to focus on cardiovascular, which started the organization, the cancers. So we all know 1 in 4 Black men will have prostate cancer, but the age for testing, it's just around 50, but we know for some of those things, it impacts and affects our community a lot earlier. So we keep chipping away, working with, clinicians and trust and institutions. Mental and emotional health. So once again, another area where there's disparity, whether it's about sectioning young Black men and, people not responding well to treatment, but the respiratory stuff as well, including COVID. Then blood-related stuff, we've been doing that, sickle cell, lupus, and others. And then reproductive and sexual health. Only recently, maternity has been taken really seriously, and the fact that, until 2019, Black women 5 times more likely during childbirth to die, and now it's received that attention. So I'll whiz through this. So for us as an organization, in order to tackle this, we're looking at community engagement and empowerment. So not just engaging with our community, not just bringing along researchers to run focus group and get information and intelligence, but making sure the community is empowered as well. We have a range of health and well-being services we run. So in response to the pandemic, we started a Black-led mental health service, providing counseling, bereavement, peer support, and other low-level mental health stuff. And we've seen to over 400 people, providing 8 to 12 sessions, and sometimes when it's complex, more than that. And we know, with the Greater Manchester Bereavement Hub that was set up in 2020, it wasn't, black people weren't assessing that, but they were coming to our service, and we've seen, over 100 odd people. But then also training, it's really important, and leadership development and all that. So we're really delighted the Health and Social Care Partnership has commissioned us to run a Black Health Improvement Program, and it's for primary care and its workforce, and there's an accreditation aspect to that. But really helping clinicians to understand what really matters to our community and how they can get the best outcomes. So proud to be in commission when some of the clinicians are, we're really struggling to get our black patients to keep their blood pressure down. And we're saying, do you ask them whether they're having any herbal remedies? Do you ask them whether, yes, they come and see you for their regular checks, but they're not having the medication because some of them feel things are too westernized. And so some of those conversations, but also the role that faith plays, when it comes to health and well-being, that's for another day. So within the Caribbean African Health Net, we have, black pastors that we employ, and their role on a day-to-day basis engaging with other church leaders, because we know if we need those low-hanging fruits and reach into our community, then going via voluntary sector organized, but also black majority churches, we can get our, people and to engage with. So we have them working with us. And then, the grants program and capacity building stuff that we've done quite recently as well. So the structural barriers we're trying to tackle is around decision-making, like I mentioned earlier on, as well as representation, making sure that black voice is in the room and pitching it in a way that is positive and can help, commissioners and service providers really make those reasonable adjustments. Also looking at benchmarking, I have a slide that I will share later on, because resources are tight and we're not naive about that. Usually it's about what will give the best bangs for the books. So therefore, how do we work with people to tailor things to respond to, those particular needs? And then racial discrimination, which I talked about earlier on, and poor community engagement. So this slide, if this is shared with you, you can see, but across many health indicators, there are disparities. So right from cardiovascular, fibroid, you have mental health there. So COVID, wasn't as bad as the poor maternity outcomes, respiratory, lung stuff. You can go on and on and on. But, whilst we're one in 4 times more likely to get dementia, it's less likely to be formally diagnosed. Until recently, and great to have the work being done by, Dementia United and, some of the Greater Manchester-wide work. We're told there was only just one person in our community living with dementia, which we knew wasn't brilliant. So we're looking forward to the census data. I know that demographics across Greater Manchester would have changed. We're looking forward to what it's going to show us. But yes, you can see 121% more likely to suffer neonatal death. It goes on and on and on, 4 times more likely to die from COVID and CVD, other CVD-related stuff. But kidney failure is there, twice more likely to have stroke, and it goes on and on and on. HIV, high rates as well. We just after the, Ygate coming, so it's there. And so for us, COVID hasn't really taught us anything new. But, there are many, many factors, and I'm sure throughout the day, various people have shared stuff. But people's level of education impacts on their outcomes. Being able to speak in a way where you're challenging your clinicians for, second opinion makes an awful lot of difference. We have lots of case studies. Language, if English is not your first language, how are you being supported when it comes to that? But also culture, what people do culturally. And for some people, because there's no talk about, herbal-related stuff, then they don't want to engage. So when we got involved with the vaccines rollout, one of the things we had to do when people were asking, so why wouldn't they tell us about prevention? We thought, and because we have clinicians who are working with us, we thought, okay, let's speak to Manchester Health and Care Commission and get them to fund some vitamin D campaign. So we actually procured, I think it was about 5,000 packets of vitamin D, 120 in the pack. So when government did the press release about clinically extremely vulnerable people and having vitamin D, we put out a further, a response to that, saying it shouldn't just be those who are clinically vulnerable. But what we know, and the data has been there for a long time, if black people, go and have their vitamin D levels tested, they need a loading dose. And what we were seeing during the pandemic, if people were ill in ICU, they were having 40,000 international units of vitamin D. So when we even had to run the campaign, and this is about benchmarking, the Public Health England guidance about vitamin D was 400 international units. We said to the Health and Care, as CCG, that no, we will go for 2,000. So we had to work with them and get that through the drugs policy team, to do that, because we knew that 400, IU wouldn't really make any difference for us. So some of those things are really, really important. But then for us as an organization, it's about how we continue to engage with our community in a respectful manner, knowing that there are historic issues that won't be resolved overnight. So yes, we've come up with a model which, you can, have a look later on. But for us, consultation shouldn't just be about gathering information and going back. So quite recently, we've been chipping away, whether we work in University of Manchester or University of Bolton or, University of Aberdeen, to say, yes, as part of your dissemination and celebration, yes, you're an academic institution, but you need to have a version that really speaks to those who contribute, and thankfully, that is being heard. I mean, that's another slide we show, but when we talk of benchmarking, it's a classic example. Eat Well Guide, it wouldn't have, our foods on there. So how do you expect people to, be healthy? Meanwhile, we know there are high levels of salt and sugar and other things in our food, and the labeling is another issue altogether. So and we're working with colleagues now, OHID, to look at what can be done. So for us, when it comes to engaging and working and wanting to take an approach to eradicating, just like we've seen around homelessness and the political weight that Andy Burnham has put behind that, and that has meant that people, many more people who are homeless can access healthcare and, other services. It's about making sure we being conscious of those differences. So we even say the black communities are homogeneous. If you're looking at black Africans, you can have Portuguese speaking, French Francophone speaking, and then others as well. So how do we make sure? And when we talk about this, and we're talking about those cultural differences, the solution is not having interpreters. It's about looking at your workforce, looking at leadership, because you need to have those cultural assets in there that can help on a day-to-day basis. And on the 7th of September, there is a piece of work we've done with the Greater Manchester Health and Social Care, local maternity system, which we're going to showcase about collaboration. And it all started because we challenged about, the embrace data and why Black and Asian women are more likely to die during childbirth. What that led to, instead of just looking at, okay, solution, let's jump on and fix it, we said, no, let's work with groups from a bottoms-up approach. It led to, commissioning about 6 Black and Asian-led organizations running focus groups. Then the findings were themed. Where we've ended up with is 13 standards for all maternity providers across, the city region, which is brilliant because it means that it's something that will have longevity. So we're even saying things like, when it comes to equality impact assessment, it shouldn't be someone sitting in the office doing it. It has to be with the community groups that they work with. So they should be more, sort of connectors. And, around maternity, I will chip in this story because stories always help. I'm watching the clock, so not to worry. But, and this, coincidentally, this is a person who is part of my church. He's a taxi driver, is African. He picks up one day a black woman, an Ethiopian Muslim, and they start talking. She was pregnant. And then they had a good rapport. So subsequently, whenever she needed a taxi, she would ask, for the company to get him to do the pickup. And lo and behold, her delivery time, came. When her waters broke, it was a taxi driver she rang. after midnight. And he had to drive over to her house, got there because he knew she was Muslim, and those who are religiously aware, you don't shake hands and stuff like that. Baby was coming out. And he was on the phone, 999 obviously rang. And then those in the call center were saying, we need to speak to the woman herself. And he said, she can't really speak English, so tell me what to do. Well, eventually, he delivered the child. But there's a classic example where language is not just having interpreters, but really understanding people's needs and then making sure that, but if you come on the 7th of, September to the cathedral for the showcasing collaboration stuff, then, you hear a bit more. But then, for us, we make references to those historic accounts. So, a lot of the work we did around the vaccine and what gave us the traction, we had one of our clinicians, he would play a clip of Bill Clinton apologizing to black people in the US for Tuskegee trial and where black men were infected with syphilis. And for some people, when they heard that, they knew those clinicians understood where they were coming from. I will never forget October 2020, we organized a webinar around the clinical trials for COVID because Greater Manchester was leading on a trial as well. In order to get people to it, we had a black GP who is also, a doctor and had been building relationship with the community. He was African. We had a Caribbean bishop who was ill with COVID on ICU, 50-50 chance. And then the lead clinician for the trial, obviously, was, a white person. When it was his turn to speak, he never showed any slides. When he said, can I share my screen? He brought a photo of his wife, who is Jamaican, his children, who are mixed race, and his grandchildren. And that was when people started asking, how do I get involved in the trial? That is what we have to deal with when we talk of some of those historic issues. And then supporting people to engage, making sure we're catering for their language. Also reimbursing people's times, because what we have is lots of service user groups, up and down the country. But usually people are expected to share their experience for free. And usually we say no. So whatever focus group we have to run, as a token, bearing in mind that when we've done stuff around mental health, we make sure there are counselors there to provide support because we're asking people to relive some of those traumatic incidents. And I think that's really important. Being very transparent when we engage with communities about what is going to happen with the data, when are we going to come back to them, and managing those expectations are really, really important. So that's a bit about the BHIP. You can have a read about that later, but we're not just delivering that in Greater Manchester. We're working in London Borough of Enfield as well. So it's a cultural competency. It's got a helpline to it where we're working with clinicians to really get good outcomes. I mean, one of the early cases that we picked up on was this Ugandan lady, victim of sex trafficking for 5 years, contracted HIV, did not want to have a medication because she said God was going to punish, her perpetrators and those who had subjected her to that. So we had to get a clinician who was also, a minister to really work with the practice and help her. But I do lots of stuff, like I mentioned earlier on, around, faith and health and well-being. And the faith angle is always critical. So whether supporting, NHS blood and transplant specialist nurses who, have someone who is brain dead and the family doesn't want to, consider organ donation because they're praying and hoping this person will come back to life. So sort of wrapping up, lots of work done around COVID. For us, really, what we're hoping for is the lessons from the pandemic will be embedded in day-to-day, healthcare provision. And then sort of wrapping up, it's more about making sure that, whatever, services we're delivering, then we're looking at, and the phraseology is personalization and person-centered approach. But that is how we can get the best from, our patients and clients and those we work with. A couple of reports, but, one on sickle cell. We did our own primary survey during the pandemic to really understand the impact on Caribbean African people across Greater West. It's on there. And then there's a vaccines report every Saturday morning. Like I mentioned, we have our health hour where we have black clinicians on the 16th of January. It ended up being a big event because we asked black doctors who had the vaccine to come forward and tell the community why they've had that. Ended up with 18 of them and 1,000 on Zoom, 800 people across YouTube and Facebook, all wanting to learn about that, and we did the report. So I will leave it there, but health inequalities is rife, know how to reach communities, and you can make a real difference if we focus on the person as a whole. Thank you.
No, thank you so much, Charles. I think structural racism exists, and I think if as a child growing up or as an adult, if you're always viewed with suspicion, if you're treated differently in a restaurant, if you're stopped and searched for no reason, or the way you are treated, the threat perception grows up, and it's a big barrier. And that obviously shows in the health outcomes that we see, and we can't address health inequalities as such as if we don't talk about these issues. And of course, we saw those sobering figures of people affected with COVID or even long COVID or other conditions with the kidneys, and even historically, even the way we were asked to calculate EGFR or in different ethnic groups, it's just, this exists, and it still exists, and you know, there's individual, there's organizational, so how can we work in it differently? How can we think differently? I think this is something for us to reflect on, and for us to break those barriers down, because we just have to think differently. People are individuals who have been through so many different experiences, and it affects them, and unless we reach out to them and open ourselves, they don't open themselves to us, and that is what creates that moment of change. But on that reflection, I'll leave you to have lunch. So lunch is there for an hour so that we can get to know each other again and talk to each other. And we'll meet at 1:30. But please feel free to keep tweeting, and it's #SHF Training Day. And do, you know, share all the pictures that you're taking and everything onto Twitter as well. So thank you once again. I'll see you all again at 1:30 for our next session. Thank you.
holding her hand, ooh, shining just for us. Let's slip off to a sand dune real soon. Kick up a little dust. Come on, cactus is our friend. He'll point out the way. Come on, till the evening ends. Till the evening ends. You don't have to answer. There's no need to speak. I'll be your belly dancer, prancer, and you can be my sheep. I know your dad is a sultan, a gnome I've known too all. With 50 girls to attend him, they all sent him a jump and spectacle. But you won't need no Helen, honey, when I'm by your side. And you won't need no camel, no, no, when I take you for a ride. Come on, cactus is our friend. He'll point out the way. Come on, till the evening ends, till the evening ends. Midnight after the way, send your camel to bed. Got shadows painting our faces, some traces, a romance in our heads. Oh, come on, come on. Oh, come on. Ooh, yeah.
Right, hello. Can we all try and settle down again as we reach 1:30? Right, thank you. It's great to see, again, so many of you here, and lovely as always, and those of you watching us online, lovely to see you again. I've got one more talk for this afternoon, and after that we'll have a workshop. So thank you so much for joining us here in the main room again, and I hope you enjoyed your lunch. Was that good? There's still plenty of lunch left, but I don't recommend going back now. But I'm not sure there'll be any doggy bags after. But the next speaker that I'm looking forward to hear is Professor Monica Lackenpaul, and she's going to talk to us about asthma and poverty. And I managed to just meet her and had a chat with her, and she's extremely busy but doing a lot of passionate work, which will come across when she talks to us. So Professor Monica Lackenpaul is a nationally and internationally recognized academic. You know, she was so international, she was just in India and flew back here on Saturday and back to work on Monday and here with us on a Tuesday. And she's a researcher, she's a clinician. She creates pioneering interventions and with the hope that they will improve the lives of the vulnerable people and, of course, the communities in the UK and, of course, globally. And Monica will be sharing her expertise on poverty, asthma, and in the South Asian communities. So with a big round of applause, can we invite Professor Monica Lackenpaul.
Thank you, everybody, and lovely to see everybody here. And I think I came because Sam told me to come, and I never say no when Sam tells me to do something. So that's really why I'm here, but also because he's been a great supporter, and so has Shared Health Foundation for all the work we've done. So a big thank you for that to Shared Health Foundation. Really here to talk to you about asthma, the lungs, and poverty. And you will know all about that, so nothing I say to you today will really be rocket science. It won't be anything that you haven't thought of, so I apologise for that in advance. But I don't apologise for trying to make us sit up and really think about the child in front of us and what is going on in their lives and what is going on outside their lungs that then affect their lives. So we spend a lot of time thinking about what medicine we should give to a child, what inhaler we should give, and we up and up and up their medication, and we wonder why things aren't working. And the problem is things are often not working because of the dynamics within the household, because of the environment within there we're in, because of the understanding of the disease, and sometimes because of the stigma that may be related to it. And until we unravel that within a family, we really can't get to the bottom of what's going on. And so the last number of years in our work has gone really from a project we did many years ago looking at asthma in South Asian families and the stigma that was attached to it and the extended family within which families lived in, to more recently work around homelessness and poverty, and then thinking about how do those two interlink. So I'm going to try and talk a little bit about that with you. So the take-home message from all of this will be, if the medication isn't working that you're giving to a child, just stop for a bit and try and unravel what's going on. Maybe go and understand the dynamics between the family, who's actually the decision maker, who's actually the person who you need to influence. Because we're so used to, in the UK, which is why I love going to India and other countries in low middle income countries, is where families live within an extended environment and multi-generational families. There's a lot of dynamics going on, and the whole family comes into your clinic and you talk to everybody. Whereas we work in a very siloed way in the UK, which is, okay, you're mum, you're empowered, you should be doing X, Y, Z, and we forget everything else that's going on at home at the same time. And sometimes we also forget the challenges the families are facing. So it's easy, again, to say as doctors, why is that mum DNAing, or why is that mum not taking her medication to her child? But actually, when you're trying to feed your child and you're trying to just fill in all those millions of forms to pay for your electricity, you know, where does it come down on the list? And it's not saying it's right for the child, but it's also a challenge for the family. So COVID, as we know, has actually caused even more problems. And that's why my talk's really about poverty, COVID, and the dangerous duo, because it was bad enough for children with asthma before COVID. It's become even worse now for many reasons, as we'll talk about today. Oops, what have I done? Yeah. So what we're going to talk about, what impacts on child lung development, direct and indirect impacts of poverty in a post-COVID era, because that's where we are, really. Well, we might not be post, but we're getting there somehow, we hope. And what approach we could take for the future. And just some take-home messages from some personal experiences. So, poverty and the pandemic. Well, I mean, you've already heard today a lot about poverty, and I don't want to give you a lot of data about inequalities because you've already had that. But just to remind ourselves that the pandemic has thrown many, many people into poverty who were not in poverty before, who were on the edge of poverty. So 4.3 million children living in poverty in the UK in 2019 to 2020. The pandemic has pushed 700,000, probably more than that, people into poverty, and it's going to go up, as we know. And 201,000 more unemployed than the pre-pandemic. So if you're in that situation, a lot of what we're going to talk about, like I said, is not top of your list, even though we think it should be. And this is just a clip from a study that was done and published this year, and I'll talk a little bit more about that as well, that children in poverty are 70% more likely to develop asthma for life. And this is a big study that was done, a cohort study that was done, and it actually looked at the linkages between maternal education, many other factors, and also poverty. And it showed definitely that there was a very, very strong link between asthma and poverty. So you will be getting to see children with asthma, but you'll have to consider their poverty levels as well at the same time and what's going on at home. And again, I'm known for trying to make things complicated, and other people try and make things simple. And the reason I try and make things complicated, because life is very complicated. And we sometimes, by trying to make it easier for ourselves, forget all the interactions and the linkages that happen between. So this picture is just one picture that I like to think of in my head, that if a child has asthma, what are all the different linkages that are happening that mean that their asthma is going to actually have developed because of these factors, or it's going to be worse than another child. So if you're in an inner city area, if you're in poverty, if you're in a household where there's many, many people, your risks are going to be higher, either of getting asthma in the first place or actually the symptoms that developed, and also being able to manage that. So you'll see here, ethnicity is known to have a factor. And it may be that ethnicity actually does increase your risk of asthma, but actually from one of our studies, the MIA study, we actually showed as well there's higher attendance rates for people from different ethnicities. And that's not necessarily because their illness is worse. It's not necessarily because they want to go to A&E over somebody else. But there's a long pathway to actually ending up in A&E, from diagnosis to understanding your disease, to the education, to who influences you in the family, to actually getting treated in the end. And it's very complicated just in that pathway, and that we can talk about in another time. Malnutrition, we'll talk about that. So the more we go into poverty, the more we're going to see malnourished children, the more asthma, severe asthma we're going to see. Overcrowdedness, you're all in a room together, you're breathing all over each other. Also pollution. If you're in poverty, you're more likely to live in a polluted area than somebody else. And then you're more likely to live in a home which has fungus on the walls, homelessness, moving from place to place where you can't keep the home clean. And then that risks infection. So a whole pot, really, of negative factors there. And what we must remember is this all starts very early on. So it starts from preconception, then it goes on through when the mother's pregnant, and then obviously from really up to the first 5 years of life, and then it continues. And that's quite important because when we think again of asthma management, we have to think of the life course. We can't just think of, okay, when a child comes at 5 years old, we're going to start treating them, because actually a lot of the damage has already been done. So we have to think about looking after our mothers. I mean, we really do have to think. We have not only kids in poverty, but we have mothers in poverty. And there's mothers who are going to give birth to babies who are small for dates, who are premature, the mothers who are unhealthy themselves in difficult environments, and those babies that are then developed and their lungs are going to develop from that. So you're giving these kids a really bad start to their lives, and trying to stop that, it's like a juggernaut coming our way. And I don't think we've got any solutions, but we need to be aware of it. So for optimal lung development, so turning it a little bit around, is nutrition. So you've got to have good nutrition, you've got to have a balanced diet, you've got to have the vitamins that you need to actually make yourself healthy. You've got to be able to exercise. And again, these are all the things that you all know about, but also are linked to poverty. You cannot exercise if you're in a tiny 30-metre squared room where there's lots and lots of kids running around, and you've got no outdoor space to be able to run around in. Where do you exercise? You have to have clean air. And we're talking about two types of clean air. We're talking about internal clean air within the environment you're living in, and we're talking about external clean air. So you saw the picture before with pollution. You are in an urban area with cars going past you, your lungs are already messed up. On top of that, you go into some of the homes the families are living in, especially when it's shared or bed and breakfast and places like that. The smoke is coming through your doorway, you're breathing in other types of fumes, which you shouldn't. The ventilation is probably pretty poor. So you're double whammying yourself, really, and getting into your lungs. So switching that round, I tend to talk, I do say the same thing a few times in different ways just to get the message through. But the risk factors then for respiratory illness are poverty, which we've been talking about all today. Lifestyle, what is your lifestyle? Do you exercise? Do you go out? Can you exercise your lungs? I mean, most of the kids we see will not be able to swim. They will not be doing sports. The environment that you're in, and then ethnicity, but we mustn't forget disability as well. And as I've said, we've really seen this through the pandemic. It's got worse through the pandemic. And why we talk about families of different ethnicities and the minority groups is because we know from the data that those are the families who are living in more crowded conditions, who are high risk of poverty, and through COVID have actually lost a lot of carers as well. So this table you can see is trying to show you the multiple deprivation score in asthma. So basically what it shows is the more deprived you are, the more asthma admissions you get. And this is what we've just been talking about. Many, many reasons for that, multiple reasons for that. But you can see the graph there that clearly shows that there's a clear link with that. And another problem that's happened during COVID was, yes, we know that people have gone into even more overcrowded conditions. So they were locked down, they were not able to get out, they were not able to get fresh air, they were not able to get vitamin D. So the crowded conditions increased. So that asthma's a chronic condition. It doesn't just come and go, it's there all the time. So the more you're exposed to these conditions, it's there in your lungs, and you don't just get rid of it suddenly. We had a lot of reduced access to healthcare, and many of you will have experienced that yourself. It was difficult for us to provide care to people. That means that children either didn't get their asthma assessed, they didn't get optimal treatment, but even more so, many of them were not diagnosed. So we have a whole host of children out there who were not being picked up at school, who were not being picked up by their healthcare systems or other school nurses where they might normally be picked up. So we do not know now how many kids are running around there where the damage has happened and have never been seen at all. And there was less health education. So we talk about asthma reviews, doing them regularly, but you can't do them regularly. Where are we starting from? We're trying to educate these children and these families. So another problem, sorry about the pink that you can't see there, but another problem is that we now have long COVID. So on top of it, we're just starting to see the effects of COVID on children as well. And we know that there's an effect of COVID on children. It's not just on the adults, but the children tend to get a little bit forgotten. And we are seeing children who are tired, they've got heart problems, they've got lung problems, they've got respiratory disorders, and they have asthma as well. And we know that those cases are going up. And again, those are the kids who will be left within school to carry on, hope for the best, and will not then be able to enter. They'll be having days off school, and they'll go back into that poverty cycle again. So I like to show people this diagram, really because it is, again, meant to be complex. It's trying to show you, again, all the linkages between difficult breathing, respiratory illness, with all of these other lifestyle factors that we've been talking about. So lifestyle, poverty, environment, resources. Think of all of those four things together. You're less active because you're poor. You put on weight, you get a respiratory illness. You're poor, you have a worse diet, you get vitamin D deficiency and other vitamin deficiencies, so you get a respiratory illness. Your environment means you spend less time outside because it's polluted, you have nowhere to run around. You get poor mental health, and you get stressed. And we mustn't forget stress is a real exacerbator of asthma, and we forget that a lot. Children get anxious, children get scared, and it exacerbates their asthma. So mental health goes hand in hand with asthma. You cannot take the two away, which is why you'll see a lot of programs now talk about yoga, meditation, and deep breathing and mindfulness. And of course, the environment of smoke, mold, and vermin, and we'll come on to vermin in a minute, and restricted access to healthcare. And the problem is, again, families who are in poverty or where they're in inequalities often pull back from health services because they're fearful. They're fearful if they've missed one appointment, they're seen as DNA'd, so they miss another appointment, then they think social services is going to come after them, so they pull back even further. So you get families really hiding from view because we've set up a system that blames families in a way. And until we stop blaming families and we can try and support families, we're really pushing them away from our health service. So this was the paper that I was talking about earlier, which really says risk factors, and it's, yeah, you can't see it there, you can see it there. Risk factors of socioeconomic inequalities in persistent asthma in children. So this was a study that was just done in 2022 or published this year. So very clear that low income is linked to asthma, no doubt about that. Exacerbations, hospitalizations, intensive care and admissions. Poor housing conditions, we know, we've just talked about that, are a key factor. And long-term stress, as I've said as well, is a risk factor. So I was talking about what I know, and you probably know from experience, but this is the data that now backs it up. And this shows another picture that they put together as well about relationship of poverty and asthma risk. And again, nothing different than what we've said, but the fact is that they've created a model that clearly explains that. And socioeconomic circumstances at birth are a key factor as well. So if you've got poor socioeconomic circumstances at birth, you then have started life off in a sort of negative way already. So it goes back to this thing about looking after our mothers, looking after pregnancy, post-pregnancy, the first 2 years of life being critical periods. So this is just to say, well, okay, you've got a home that looks like this. What do we do about it? You know, you can't move around. You're living in cramped condition. You try running around with 3 kids like that. It's absolutely impossible to do. And then you have a home like this. Where do you store your things? Where do you store your medication? How do you access it? What do you do about it? You know, this is the real lives of what people are living in. And then we see them in a surgery, and we just go, here's your inhaler, go home, make sure you take it. And we forget about everything else that's happening. So just a few snippets from some of our work about what people have said to us. And these are just a few. I mean, we've got hundreds and hundreds of quotes. This is just one slide to really bring it to life a little bit. So my daughter kept being sick because of stress and lack of sleep. And that's key. We talked about, I try and talk about the 3 S's, stigma, sleep, and stress, really. And those 3 things go together. If you have asthma, many kids are stigmatized at school. They daren't show other children that they've got asthma. They are stressed, they are anxious, they can't breathe properly, and then they can't sleep at night either. They wake up all night, and then they can't go to school. Poor education, back into the poverty cycle. Access to food drastically dropped. You don't have food, you can't have your vitamins. My daughter's slightly asthmatic, so we had to increase her inhaler. But the parents didn't really know what to do. They couldn't engage with anybody, too scared to access healthcare. And we had loads of insects, and there were mice outside. We forget that even in the UK, a lot of these homes have lots of vermin, and those vermin carry infections, and those infections trigger off your asthma. So malnutrition. Why is malnutrition important? Well, it impairs lung development. We know that if you're malnourished, you don't have enough vitamins, you don't have enough nutrition, your lungs do not develop properly. You then have a decreased immune response, so you can't fight infection. So if you can't fight infection, your asthma gets worse. And then you can't recover either from the illness. So it just goes on and on and on. So unless we actually feed our children in this country better, and that's a big problem we're going to now have, we're going to have increasing chronic illness, increased malnutrition, both hand in hand. And then vitamin D, we know that you're locked down in COVID, you're locked down even now. And if you don't spend time outdoors, you're going to have a lack of vitamin D. Very, very clear evidence that vitamin D actually regulates immune function. And if you're deficient in pregnancy, you can get child lung problems as well. So again, think of the mother, think of the child, think of nutrition. If you have reduced immunity, which happened a lot during the lockdown, you're exposing yourself to a lot of different pathogens as well. That then affects your immune system and your illness severity. Again, what I'm trying to show you is this it's constant. If you're looking at these families, unless you tackle the food problem, you're not going to tackle their asthma problem. And we have another problem on top of it, is respiratory syncytial virus. Many of you will have heard of RSV, and RSV was pretty prevalent, and it's always prevalent in the winter. So in winter 2021, and weirdly, it went down a little bit, and then it went up in the summer, and we think this is because of the interaction with COVID, children not going out as much. But it was predicted it would go up last winter, and we think it's probably going to go up this winter. Kids are back at school now. They're all mixing again. The infections are going, and we're going to have another. So be ready for the winter. RSV, asthma triggers all coming together. It's coming our way. So I won't talk about this too much because we've already talked about this, about pollution and passive smoking. I mean, we haven't really talked about smoking, but again, a lot of individuals in poverty are exposed to other types of fumes. So there'll be the car fumes, there'll be all of the fumes due to different drugs and things like that that they come across, and there'll be passive smoking as well. And how do you actually protect children from that? Vermin, like I said, I'd love to have a whole thing on vermin because actually we don't talk about vermin. And it's a real risk factor for families. We have heard stories of, and you all have heard it, I'm sure Sam's heard it, of kids with, rats in their cots or cockroaches running around, them sleeping on the floor, carrying infection, and we don't really tackle that at all. Damp, mold is there. But one thing that's going to also hit us hard is no heating. So we talk about no ventilation, you can't open your windows, you've got damp in the room because you're hanging your clothes up, because you wash your clothes, where do you put the clothes to dry? And then you put them on a line, you can't open the window, it gets moist and the mold starts growing and growing and growing. How do you clean that environment out for these children? And to just demonstrate that, there's this slide showing the environmental and illness cycle, which I put together, which is about if you have poor housing, you're going to have increased respiratory infection. And the problem with increased respiratory infection is your metabolic rate goes up. So you're breathing harder, you work harder, you then need more food. We've talked about food, I keep talking about food more than asthma. You need more food to actually feed this metabolic rate. You have insufficient nutrition, which we know, and it was only on the news yesterday, somebody saying, which was really quite shocking, well, people will adapt their eating habits because of the current situation we're in. Okay, that's great, thanks very much. These kids are not going to get any food because you want us to adapt our eating habits. And then you get poor immunity, illness, infection again, and you go round and round and round, and you never break that cycle. So this is just really bringing us back to some of the work that we've been doing on incident rate of child illness with in homeless families. So if you're homeless, you are going to more likely to have respiratory infections, skin ailments, gastrointestinal problems, and chronic physical disorders as well. I mean, here we're talking about the respiratory disorders, but everything is going to be higher. So if you've got one, you're going to have all of the other things going on, and you'll probably have eczema, as we've talked about, skin ailments, and those often go hand in hand anyway. Just looking at that. So we have another problem that happened during lockdown, which was no school meals, and I know that there's constantly a fight to get rid of school meals. So one plea is we really need to make sure that doesn't happen, because if we get rid of school meals and we get rid of all the breakfast clubs or anything else, it's going to trigger all these other problems that I've been talking about. We didn't have structured exercise, we didn't have play. Children don't know how to use their lungs anymore. They don't know how to swim, they don't know how to breathe. They don't do music if you're in poverty. So you'll talk about other children who can play the saxophone or play this instrument or do whatever. The children actually have not used their lungs. So how do we get our children to exercise their lungs? If you've had an accident, you're often given a balloon, and you're often given that balloon to blow up. Simple exercises that we do. But these kids are not using their lungs in any capacity at all because they're not doing all the things that I've talked about. And they spend a lot more time often at home in the household. And just to hit hard again on the final slide of this bit, which is about pregnancy, for all the people who are involved, who are midwives or look after mothers as well, that time inside utero is key. And so whenever you see a mother in your clinic or who's pregnant, please just think, what is her mental health? What's happening with her diet? What's happening with her exercise? And what are her environmental triggers? Because that will protect the baby that she's going to give birth to later on. So we talk about a bit of access to diagnosis and healthcare. Well, from our data in our MIA study, what families were basically saying, it was an interesting study, it was asking families really what they felt and why they felt that asthma wasn't being recognised, why they felt they couldn't improve the health of their children with asthma. And we also asked professionals. And when it came to professionals, they felt it was because people weren't educated, people didn't have the knowledge, we had to do more education. People didn't speak the language, so we can't speak with them. And actually what the families were saying, it was nothing to do with that. It was to do with the fact that first they didn't nobody recognised that their child had asthma because the symptoms are so vague. When they went to the doctor and said, I think there's something wrong with my child, if it wasn't severe enough, it was like, go home again, come back later. If they left themselves sitting at home and ended up in A&E, then they were told off for going to A&E because they were not utilising the services properly. So then they were scared to go back again. So getting a diagnosis was a key part of actually starting that pathway of treatment. We know that families during COVID were not accessing care, as I've said, and they were not getting physical examinations done. And we have a whole list of children now who will not have had that assessment done. The question for all of you is, what do you do about that? So again, I learn a lot from when I go to India. It's like, they have big programs and they do invest in big programs, and they realize that every child cannot see a doctor when they need to see a doctor. And it's tragic that they can't. But then what they have to do, and I don't know if this is right or wrong actually, and I go through this ethical dilemma myself, but they will hold what they call health camps, where children who want to overcome that barrier of going to a doctor can just turn up, get assessed, talk about their symptoms with a no blame sort of situation, and do their peak flow or do whatever assessment they're having, and then at least the families feel that they've shared their problems and they can see, I don't know, do we need to be doing something like that here? We have so many children who are not diagnosed with so many problems sitting out there. So for anybody who wants to read the report on the MIA project, this was called Management and Interventions for Asthma. It's got a big report and it has all recommendations in what we could do. And one part of that was an integrated approach to, it's called Act on Asthma. How do we set up training programs across GPs, paediatricians, families, third sector organisations that actually say the same thing so we don't confuse parents. Parents are very, very confused at the moment, don't really know what to do. And so when you're in a situation with all of these environmental triggers I'm talking about, you're going to be really, really confused with how you should manage your child. The other thing I just wanted to remind people of is family bereavements. And the reason I'm bringing this up is because during COVID, lots of children lost lots of people, whether it was families, whether it was friends, whether it was peers. And when you're homeless in poverty, you have bereavements because you keep moving. And people forget that actually bereavement in itself is linked to asthma as well. And you might think, well, how is that linked to asthma? But if you've lost your caregivers, you've lost the people who look after you, you actually don't have the main person who's going to give you your inhaler or going to know about your inhaler. So we have to think who actually in the current time is looking after these children, and who do we influence and who do we educate. So again, this just call the mother in system that we have may not actually be a system that's going to be sustainable, and we might have to think a little bit out of the box. So what next? What next for all of you? What next for us? Well, what we've been trying to think of is how do we develop systems that actually consider linking up all of these things that we say. This was a different project that we've been doing. But we really talk about holding hands together across all of these different factors that I've talked about. We have to work across health, we have to work across education, we have to work across politics, and we have to work with engineers and people in environment if we're going to actually crack this problem at all. We have to understand the link between them all, but we're sitting here mainly as health experts, but actually we have to also link with all the people in environment who actually change what's going to happen to our children. So we need a One Health approach, which we talk about. One Health is often considered when we talk about vermin, or we're talking about animals and transmission of infections. But I try and think of One Health as it's like the WHO talk about it, an approach to designing and implementing programs, policies, legislation and research in which multi-sectors communicate and work together to achieve better public health outcomes. So we won't achieve anything on our own in a room. We have to really work together with all our partners in the different sectors. It's not easy, and I know that because we bang our head against a brick wall many, many times trying to do it. and we only have so many hours in a day. So just to think, some take-home messages are the health, education, environment sort of approach. With that, how do we put the child at the centre? How do we holistically think of the future of our children? We need the government to really address social issues, such as poverty, such as nutrition. When it comes to health, at the moment, the two are divided. This is about food, that is about asthma. Even in our own integrated systems that we're now going to have, we have children's health separate, mental health separate, homelessness separate, poverty and other causes separate. The child doesn't look at it in that way. So we need public health approaches that address environmental factors with us in health and education as well. And education is very key, because if you're not healthy, you can't be educated. Researchers and funders need to consider those linkages. At the moment, it's very hard to get funding for these messy research projects. People want randomized controlled trials. They want very clean research studies that can show you an outcome in 2 years, which is nearly impossible to do. So we have to think in other ways, advocacy, campaigning, whatever we can do. And healthcare providers, we need to treat the person, the child, not the symptoms. We often think about the symptoms, oh, their asthma's going up, their wheeze is doing this, and we forget the child at the centre and what they're going through. And we have to consider the barriers that prevent families coming to us and prevent them getting access to what we have to say. So integrating respiratory health into the overall health and wellbeing agenda is probably what we need. So I'll just leave you with this last slide. Our children are the rock on which our future will be built. Our greatest asset as a nation. They will be the leaders of our country, the creators of our national wealth, those who care for and protect our people. So thank you all for coming today, and lovely to speak to you all.
Thank you very much, Professor Monica Lacanpo. I think you're leaving straight away, so I'm just wondering if somebody has got any questions that they can ask you. Yes? That was a very interesting and stimulating talk. I've got a question. So one was, you see the relationship between asthma and mental health, and working in A&E, you do see a lot of patients coming in with overdoses, and then you also see that they have a background of asthma. So is there a link that's already been established, or something that people are looking into? Thank you.
Sorry.
But you're welcome back here.
No, it's all right. But yeah, just to say that I think the link between asthma and mental health needs to be done more. We do know the link. There is a link. And like I said, that's why we're bringing in much more of an approach of mindfulness, meditation, trying to talk about stress management, basically, for individuals. But it's not, I haven't seen a big wave of that, and I haven't seen a lot of research linking the two. There is research around like yoga and asthma, but not what you were talking about of, is the overdoses and everything linked to asthma.
Oh, thank you. There's another question from Liz. It's the microphone.
Sorry, could you just repeat the question?
Yeah, sorry. A lot of our parents are trying to stop smoking, for themselves and hopefully to help their children. But a lot of them are vaping instead. Is there any evidence that vaping is a problem?
Yeah, there is some starting to becoming evidence coming out, and I think it's all of this thing about, it's all about risks, isn't it? It's like anything that basically gets into your lungs is a risk of triggering your child's lungs. It's like anything, whatever it is in the air is going to, the cleaner your air, the less risk it's going to be. Now, the problem is that, you know, I'm always hesitant sometimes because actually what you want to say to parents is give up smoking, give up everything, don't have anything at all. How realistic is that if they've got all the other stresses? So sometimes you have to come to a negotiation and say, okay, you do realise this will also have an impact on your child. However, it's better than, probably better than smoking. The problem, again, we have is that we push very hard and advocate very hard that families should smoke outside the room and outside the bedroom or outside the house and everything. And people have sort of got that in their heads now. But the problem is that they don't tend to do the same with vaping because they think that's okay. So we have another problem on our hands that are we actually exposing our children because we've tried to solve one problem, but we've just brought in another problem.
Sorry, what about cannabis? If the parents smoke cannabis, does that affect them?
All of them. So that's so when I was talking about trying to talk about homelessness and living in bed and breakfast and in all of these different really confined areas and the smoke getting through the door, again, it's any sort of fumes, any sort of any particles basically in the air is going to trigger your asthma, whatever those particles are. And that's again the problem when you're in those sort of accommodations where even if you as a parent are trying to do your best, but you're put into housing where there are other people who aren't, you're going to expose your children to it. And that's not those families' fault, really. And again, when we talk about homelessness, that's why we really try to advocate for families being in family accommodation. But it's again, difficult to control, isn't it?
Would it be true for things like a lot of Indo-Pakistanis and Arabic communities, they do bukhur and stuff in their homes, and it's still fumes, isn't it? So is that still as damaging?
It still fumes. I have to be very honest, I don't know the extent of the damage, but it will trigger the asthma symptoms. So what I can't say is, you know, I'll be very honest, I don't have the data on, you know, how extensive the damage would be on a child because I haven't read those studies that talk about the extent of damage. And I don't actually know if they've been done or not. But it still comes into the same thing of any particles that get into your lungs is going to be harmful to your lungs, whatever. And you're right, those conversations haven't happened. So we do know from data, very clear data, is that it follows the same thing as like cooking fuels. If you're in a country where your cooking fuels are wood, it's very damaging for children's lungs. In the Asian houses where you have incense, again, people don't realise that if you burn incense, that incense fume actually is damaging to the lungs. And this is why we're trying to advocate that if you think a child's asthma is not controllable or there may be household environment, a home visit is really, really useful because then you can actually see what exactly is going on at home. If you ask a family to come in and tell you all these things, they're going to really feel quite victimised and quite stigmatised. Whereas if you just sort of can see what's going on in the house, we might have a bit more of a way of approaching these discussions. But being culturally sensitive as well, that's the thing. You don't want to alienate the family. So it's really this juggle of not alienating them, but helping them along to understand. But like you said, a lot of professionals don't think about all of these other triggers either.
Just in regards to the rollout, kind of you said in India, where you have these big programs, could that not be done in schools here? Well, let's say at the start of the year, or for year sixes that are going to go into secondary school, to do it at that point, and then you can have the conversation with the parents, maybe at parents' evening, saying, look, the child shows signs of potential asthma, it's going to affect their learning, and engage with the parents that way, so it's not so onerous.
And completely, and when I started out my training, many years ago, you know, school health was a big thing. That's exactly what we used to do. It was all about assessing children in school, assessing children when you saw them, when you had access to them, to ensure that you did that. I know you've been talking about dental health. You know, you used to look at the dental health, you used to look at their eyes, you used to look at their general well-being, and you had a holistic assessment. That was cut from the government funding completely. It's all gone away, and now we don't have that. And now we rely in this country on individuals being able to access care, which actually, there's a thing called the candidacy framework. It's like you have to be able to, there's many steps that involve you going to see a doctor. When I go to see my doctor, it's hard for me. I have to ring a phone, I have to get an appointment, I have to feel confident, I have to not feel they're going to tell me off, I have to feel that I can explain myself, all in a very short amount of time. It's impossible for many of these families to do this. But where they have an avenue where they can literally, like you said, walk into a school camp or walk into a school well-being, I don't like calling it a camp, but, well-being day, and be able to be assessed, it takes away a lot of those barriers. I do think we have a lot to learn and a lot to switch back to the way we were doing things quite a few years ago, because we're going to be in a crisis otherwise. Or we are in a crisis.
No, thank you so much. I think it just one condition, but puts the spotlight on what we need to do, because sometimes you can't manage asthma better unless you actually visit the home. There's no point talking or teaching more inhalers unless you actually see how they live. And it's such an important take-home point for us as GPs or clinicians working, because you need to understand the home setting, and that's just one condition. And people don't come with conditions. People come as people, children come as children, and I think that's the beauty of general practice, and that's the reason why we are here. We need to treat them as individuals with things, with illnesses that happen, but it happens because of the lots of different inequalities that we talked about, including poverty being just one of them, but there's just many more. So thank you once again, Professor Lacombe. We benefited a lot from that, so thank you. So the next, we've got a workshop, and it's about all the things that we've learned. It's about how we put them into practice, and it is over to Laura. You can still clap your hands.
Right, so what we're going to do now is we've got half an hour now, and then guess what? Some more coffee. So we've got half an hour now, then we're going to have coffee, and then we'll do a short bit afterwards. Is that all right? And this is an opportunity for you guys to talk together. So some of you have come as PCNs, in which case you can go in your PCN huddle. There are certain rules. You're not allowed to have a punch-up here. That's for like your PCN meeting. Is that right? So you can go in your PCN huddle, or if you're from an area you want to talk together. If you're completely random, then we're going to have random tables. Is that all right? So no one gets left alone to talk to themselves. And what we're going to do, the first thing I want you to do is just find a group that you feel comfortable with. I think kind of groups of like 4 or more are good, because otherwise it gets a bit awkward, doesn't it, if there's only 2 of you. So kind of 4 or more is good. And a couple of things I want you to talk about to start with. We're going to give you 10 minutes to talk together. So that classic question of what have you learned today? So this isn't about thinking of projects for the future. This is just things that you've learned today that surprised you. Okay, so I have learnt from our lovely dental friend that you can prescribe high fluoride toothpaste on the NHS. I did not know that. So if you see someone in general practice who's got terrible teeth, you can prescribe high fluoride toothpaste on a normal prescription. It's great, isn't it? I know. You can prescribe high fluoride toothpaste on a normal prescription for people who've really got bad teeth, which we don't have fluoride in our water around here for some weird reason. So that's something I learned. I did not know you could do that, but I'm up for that. Other things I've learned is apparently asthma is chronic, and my asthma won't just vanish. That sucks. So that's another one. So just little things that you might have learned in the talks, or things that intrigued you. Like I had not made the connection between vermin and asthma, I have to say. And I've been to a lot of houses and seen lots of vermin, so I'd not made that connection. So just what are the connections that you've made? We've had quite a variety of talks this morning, so just share together. And it'd be helpful if you could write some of them down, because we'll need them in a bit. Is that all right? So we'll have 10 minutes, and then we'll set you on your next task. Is that all right? Right, so let's have a think then. What I was going to dance then. Do, 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 do. I know, we could do that later. So there's lots of chitter chatter. So anybody want to share some of the things that they've learnt today? Oh, someone's pressing their phone. Oh, it's Simon. Hi, Simon. Right, has anyone learnt anything apart from me? Go on.
So I'm from a secondary care background. And, thank you. Sorry. And I was thinking about the trauma-informed dentistry, and that there's departments within my hospital in gastroenterology and in surgery that things are put in people's orifices with or without sedation, and no real consideration of what those kind of aspects might be. And that's an area that I think maybe it could be thought about what we might want to do there. So that was one thing.
So yeah, that kind of trauma-informed care, kind of the more medical interventions we do and the less choice people have when they're being undertaken can have all sorts of ramifications. So I think there's lots of areas of medicine that we probably just get on with it, don't we? And that might be quite difficult for people. So I think that's really interesting. Anything else that people have learnt today? Oh, good.
Well, we had lots of wide-ranging chats about lots of things, but I think the thing that I took away was and others have been no hard-to-reach groups. Yeah. That really resonated with me, because I think we do put people in a box of, we can't reach them, it's difficult, but it's definitely about access, isn't it? And like how the service is set up for their needs rather than for our needs as providers. So I'm definitely going to be taking that one away.
Yeah. No hard-to-reach groups, that was a great tagline, wasn't it? Said with full passion. Anyone else got anything they've learnt today? Oh, come on, there was loads of chit-chat until I get the microphone out. Oh, good.
We had lots of different discussions, because there are people who are probably more new into this role and people that have been here for a long time. But I think the one that that we all had learnt from was the soothing and the alert model, where we were trying to put that into practice, and how we already do that, but then referring it into the ways that they're working and terminology to patients for saying, the appointment types that we think we'd all took that away. And then the CAN group, we said, really good work that I think gets missed in the networks. The trauma-based dentist, we hadn't heard of that. And then the stress and the links to asthma was a really good presentation that we'd all learned. So a few bits.
Cool. Anything else? Oh, Liz has always got something. Oh, sorry, I said that, didn't I?
You'd miss it if I didn't say it. No, only that oxygen is the only molecule you should be breathing.
Thanks, Liz. No further comments. Cool. So some of those things that you learn are kind of interesting, isn't it? And we deliberately, when Sam put today together, we tried to make it broad so that there would be different things that we could engage with and just stretch our thinking. So before we have coffee, the next thing I want you to do is, on your tables, is think of a story of a patient you've seen if you're a healthcare professional, someone you know in your community or someone you've worked with that's really bothered you. So I often think change comes from the stories that just unsettle us. I love stories. And the patients that, I really like the patients where I know the diagnosis and I get it right, because I'm like, woohoo, I read some textbooks. And the patients that are kind of complicated but have dignity, I'm okay with. Do you know what I mean? The kind of people who are dying and they die well and that kind of thing. And then there's this whole group of patients that just niggle me. So I just want you to talk together about patients or stories that niggle you and why. And sometimes you don't know why they niggle you, but chatting together can sometimes help. Is that all right? Then we're all going to have coffee and you're going to come back and then we're going to talk about the PCN stuff really short. And then we're going to look at what can we do in a PCN. So we're going to pick one thing And if you're in your imaginary PCN, this would be a great PCN, by the way. I would be in that PCN. But if you're an imaginary PCN, then you can pick something. Because, you know, if you even just look at the presentation we've had today, we've had, you know, dental prevention, asthma, lots of things we could pick as our thing for health inequalities. And then we're going to think about what we can do to improve that. Is that all right? So, but before that, the patients or the stories that have niggled you. Is that all right? And we're going to have dancing music whilst you're niggled. Is that all right? And then we're going to have coffee and then come back.
Chat
stay with me in the morning. You only hold me when I sleep. I was meant to tread the water, but now I've gotten in too deep. For every piece of me that wants you, another piece backs away. 'Cause you give me something that makes me scared, alright. This could be nothing, but I'm willing to give it a try. Please give me something that someday I might know. You've only waited up for hours just to spend a little time alone with me. And I can say I've never bought you flowers. I can't work out what they mean. I never thought that I'd love someone that was someone else's dream. You give me something that makes me scared, alright. This could be nothing, but I'm willing to give it a try. Please give me something, 'cause someday I might call you from my heart, but it might be a second too late.
Okay, so there's coffee if you want it, so you can grab coffee and come back, or go for a little walk. What we want you to do is think about in the PCN. There is some money for tackling health inequalities, and every PCN has to come up with a project. So we know that some PCNs have got their project sorted out and it's like going strong, and others have yet to think about their project. So, and the other thing is that obviously within the PCN stuff, you can fund some of the R's roles, and you can use some of those roles quite creatively to tackle some health inequalities. So what we'd like to do is not necessarily worry too much about the technical DES, because if people come up with ideas, there's probably ways around of making the money work. But what we do want to do is people think of stuff they can actually do. So that's the next bit. So after coffee, we're going to think about that. So Holly's looking, I'm not looking at Holly with this. But like what we want is some kind of, we want you guys to actually think creatively. So a lot around the country, some of the PCNs have done some phenomenal work around health inequality. So some of the stuff they've done is to do with coding or a specific group of people or a specific disease, or, you know, and they've really mobilized to do it. So what I'm saying is that we want you to think of what one issue you could tackle locally, okay? And one thing that you could have a conversation about when you come back as a PCN. Now, some of them you'll be able to do, and then some of them you won't be able to do, but actually it may well be that Shared Health will pick up some of these, these brilliant ideas, and try and work with you to get them done anyway. So what things could you tackle and how? And then, so if you're going to come back at 3, we're going to have a kind of quarter of an hour thinking about that properly. And then what we're going to do is going to play, I want to do this, but I don't know how to do it, bingo. Is that all right? So you can sit there and you can go like, I've decided that's what's Liz going to do. Install oxygen cylinders into everyone's house. Pump it through the air of the schools. And not have Bunsen burners on the desk. but like, whatever your idea, we're then going to have a kind of, I want to do this, but I don't know how to do it, okay? And there'll be some of them that are totally like not very doable, or some that are too big that we go, that's really fascinating, we're going to put that into a different space, I'm going to come back to it. But there'll be some that we can go, actually, that is probably doable. And some of the worries that people have are really solvable. Is that all right? So we're just going to hopefully help people in PCNs move forward a bit. So have a cup of coffee, and then on your tables, I want you to think about these ideas that you can do to health inequalities in your area. Is that all right? Right. So it's brilliant to hear everyone chatting. This is good. This is the bit where we're gonna think quite hard. What can we actually do? So I know when you think, I know when we think, oh, what can I actually do? That it feels really overwhelming. Okay, so if you go home today with a list of, I'm going to sort out dentistry, I'm going to sort out asthma, I've got to tackle rats, secondary care. We're going to do compassionate care through the whole of the hospital tomorrow. I'm going to, systemic racism needs tackling, past sexual trauma needs tackling. If you go home like that, and then you turn on the news tonight and it will say cost of living, inflation, Boris, Ukraine. And by the time you get to 9:30, you're like, oh, crikey. All right. And then it's easier to go to work and hide in the kind of busyness of everything else that happens. So there is always millions of urgent tasks that need doing. There's always patients to see. There's always medication to be prescribed. There's always emails, endless emails. It's always stuff to do. And we can spend our days being very, very busy, but not actually that effective. And so this is a little pause where we can decide we're going to do something. Okay. Now, some of the projects you've heard about today started because a couple of people decided to do something. So do you remember back to the little running group, 8 women running every evening? It's fairly good, isn't it? That's not massive. The child poverty, hunger stuff started off with one, summer they had a go. We talked to them, they had a go, it was a disaster, they learnt, and now it's kind of grown and grown and grown and got better. So a lot of these things start with quite small things. And the best way I've seen of changing stuff is for people to be genuinely passionate about the stuff they want to change, which is why you pick the topic. And the PCN stuff does actually allow you to do this. I've never seen this in 12 years of health, where you get to pick something you actually want to do. Like normally they go, this is a new scoring mechanism for some random disease. Please do it on all your patients. This is a new quaff target. There's very little choice in a lot of what we do, but this is a moment where we get to choose. So it's quite a good moment. And whatever your budget is, which you probably don't know, that's fine. But the budget, will be somewhere between like a couple of quid and a couple of, maybe up to about 40 grand you'll have floating around somewhere. So it can be overwhelmingly big money and people go, oh, we have to use it really, really well. Or it can be like too small to change the universe. So don't think about all those barriers. Think about the thing you're going to change. Is that all right? So the combination of either stuff you've heard today or stuff you've read about on Twitter or patients that have niggled you or just something you're like, this really annoys me in my surgery. Let's try and come up with a couple of things that we can actually change. Is that all right? And then we're going to share how do you actually do that. So don't get caught up in that, but then that role doesn't exist, that person exists, who's going to manage them, how am I going to get the budget out? What are they going to say? Where's the chair? Has anyone got a chair in their surgery? Everyone goes, no one's got a chair. Can't have any more people, no one's got a chair. So, all those things, just park that for a bit and what things you actually want to tackle. Is that all right? And we are going to go around the room. This is not a commitment. I'm not going to come back in next week, in a year's time, and go, you said on that date that you were going to. This is just so we can encourage each other a bit, that we've got some ideas. Is that all right? And you might think your idea is naff and you're going to upgrade to their idea. So that's fine. Okay, we'll give you about 10 minutes for that. Is that all right? And if you're not in primary care and you want to do this in wherever you work, that's fine. You can all play the game. Is that all right? Change the world game. All right, ready, steady, go. Right, let's have a little check. Have you all ordered your dinner on delivery or something? So, has anyone got any ideas that they'd like to try? No one dare speak. Oh dear. Yes.
Yeah, so we'd like to set up something for patients to help them with their diet and with what they're eating, because it has come up in quite a few talks, the asthma talk and everything really. So, yes, not quite sure exactly how that's going to happen, but yeah, some kind of patient support group. Thought initially people with diabetes to help them think about what they're eating and ideas to what they could eat and how they can cook and how they can shop and all the rest of it. But as a side effect, also the weight would probably go down as well, but then also their mental health hopefully would improve, and skin and joints and asthma and all the rest of it. So we thought maybe about some kind of maybe group consultation or possibly some kind of cooking club or something like that. So they learn the skills as well of cooking and knowing what to buy and what to eat. What else did we say? Yeah, that was kind of it really. Just a bit vague, but yeah.
I think there's quite a lot we could do around food. We have definitely had a cooking club in the past. The side effect of that is you get lunch cooked by them, which is great. So we did it in our upstairs room in our surgery, got a little electric 2-hob thing. So it wasn't particularly fancy. Turn the smoke detector off that day in that room. And yeah, I mean, we definitely had a cohort of patients who came, had fun, did it. There's a couple of things about it is that you don't have to have massive numbers. So when you look at your diabetes list, there's one surgery that I look after that I think there's over 560 diabetics or something. And when you think about 560, it's just overwhelming. And then if you think, well, I'll get 5 people to my cooking club, you can think that is a drop in the ocean. But it's interesting because that it does have a knock-on, and it also has a knock-on to your staff. So the people who are in the building are more diet aware. It at least happens once a week. The building smells nice. There's a kind of easy recipe that's shared around. It can go on the website. So there's stuff that kind of ripples from that, even if it looks like there's 5 random people cooking dal. Do you know what I mean? And it's a start, isn't it? And I think some of these are just small starts, isn't it? You can use ours money for dietitians. You can use some of the care coordinator roles, clinical coordinator roles can be used for quite interesting stuff around diet, and wellbeing coaches are all in there. So if you're in a PCN that hasn't got an R's plan, which most of them in Greater Manchester don't, that's something to look at. So there. But yeah, definitely have a go. And the other thing is that you can work with lots of third sector organisations. There's a wonderful third sector organisation called Cracking Good Food, that's the one. And they'll come and do sessions for you in your surgery to kind of get you going, and then they'll help you start off. So yeah, that's I think that's a goer. As ideas happen, I think that's a goer. Yeah, any other ideas? Oh, and everyone's really nervous now, aren't they? Go on, Alan.
We had a few different ideas, from apps to using Alexa, but one thing I thought that I would like to explore really on leaving is this concept of threat and soothing. We did as a CCG have an exercise before where we opened up the chimp paradox and learning to all practices. And I wonder if we could do something similar at a practice level or a PCN level for soothing, so that our practices could become soothing practices.
Yeah, it would be really interesting, wouldn't it? How do you become a soothing practice? I'm really intrigued by soothing because it feels more doable than resilience to me. Like resilience means somehow I'm going to be a marathon runner and then my muscles won't ache the next day. That's kind of, just have to work harder and get better and more resilient and work harder. And I think soothing for me gives permission to not do stuff, to slow down a bit, and just those thought processes. I heard Jen's talk a couple of months ago, and even in consultations, realizing that I'm acting out of threat or drive, and the patient's acting out of threat or drive, and then we're making each other get more and more like, but, and just even me going, just breathe, just breathe. You know, even like telling myself, just breathe, has shifted stuff in me, even if it hasn't. And I think it then shifts in other people, doesn't it? So, yeah, how do you become a soothing place? Particularly for our receptionists, I think our reception staff are absolutely battered some days. So how do we create a space for soothing? Generally, I think that's really interesting, yeah. Be nice, wouldn't it? Don't buy lavender though, will you, Alan? That's what they did in A&E. In the middle of COVID, Captain Tom was there with his walker, and we got some lavender. I was like, it's not really going to help, is it? Let's be honest. Anyway, any other ideas? Yeah. Of course it's not fully formed. I had 10 minutes.
We wanted to sort out our new mums. We wanted to help them out because we were worried there's quite a lot of new mums who had a lot of issues in their lives, and we were reflecting on how important that birth to 1 year is in terms of development and the knock-on effects as a result of that, and any trauma that might have been experienced of that. In terms of how we were going to do that, we're a little bit unsure, but one thing we were thinking was, could we have kind of a named professional or worker who would be assigned to all new babies when they're born, and it was sort of, they could then follow them up, and could act a little bit like kind of shared care and do some signposting or some sort of more in-depth things. We also wanted to make sure we could do it from the perspective of the new mums as well, and maybe do have some peer support, because what we think might be important for new mums might not be what they think is important. And there's probably some value in having someone who's gone through that process and who is a new mum themselves, being able to model that. So yeah, that's sort of where we were at. What did you say? Sorry, parents? Oh, and dad. Well, that's a good point, actually. I didn't even mention about the dads in this, but yeah, we were quite focused on the mums. But yeah, any other suggestions around that would be helpful. And yeah. Yeah, exactly, yeah. So it's going to be based on what we were finding the needs were from that cohort of people.
Yeah, I think new mums is really fascinating, isn't it? Like I feel, I'm not looking at Alan now, I feel quite old. But like we've had Sure Start, we've had, do you know what I mean? And it comes and goes, doesn't it? And it does feel at the moment there isn't an awful lot for new mums, I have to say. And it's such a difficult time, isn't it? I think it's the consultation I love the most is the crying new mum. I just love it. It's like my favourite consultation to do, because very rarely is the baby sick, are they, really? But it's just, and I was a crying mum. I did a lot of crying. So I feel like I can do that one. And it just makes such a difference, doesn't it? So I think having something for young mums is really cool. Whilst I'm yabbering on, should I tell you that when my first was born, I was quite young and I lived in Fitton Hill. And so I kind of got categorised with that. And Barney cried all the time, like all the time. And I think he probably had this thing called reflux. Nobody told me about that. So the health visitor sent me to baby massage that was on at the time. So I went to this like baby massage centre and took off all his clothes and was massaging away. And obviously I was probably quite tense, like up here. Anyway, this squawky thing, who was twice the size of all the other babies, cried and cried and cried and cried and cried. And the woman said, I think you're upsetting the other baby. It's probably best you don't come back next week. So I tell him that he was expelled at like 4 weeks old. So yeah, but what's interesting is I never went to a baby toddler group again, ever. Not even with the other three. Was like, could not go in. Even though the two were better behaved. So, but I think looking after new mums, isn't it? We know, don't we, the first 200 days is so important. We know increasingly that our health patterns are set when we're young. You know, we know the mental health of our mums and our dads is really important. So yeah, I think anything that can help young mums is helpful, isn't it? Even if it's like, can we have a member of our practice team just ring them every fortnight and be like, are you okay? They don't have to be medical, do they? But just a nice, kind person going, we still know you're alive. Are you still alive? Oh, good. You know, I don't think it has to be massively medical, all this stuff. You know, can we do a toddler group in the waiting room? We've definitely done them. You have to disinfect the toys. But, you know, there's lots of things that are very low cost. I think we can do that at least help a bit. But yeah, if you in public health could allocate a key worker for every new mum, yes, go for it, sort it out. Yeah, yeah. Just contact, isn't it? Contact that's caring is really helpful. Oh, this is good. Yeah, you can immunisation them on the way. Anything else? Any other ideas? Go on, Michelle. Go on, be bold. Simon's not here, he'll never know you said it.
I don't like talking in a microphone, but I don't mind. So we had a couple of ideas for different health needs, and there's quite a diverse population in Oldham South. So we went with the idea that we do targeted targeted health promotion on a monthly basis, and we would work with people like Focus Care and Action Together to go out to the groups and promote things like smears, childhood immunisations, and work with those community groups to promote it within those community groups. So I can't remember what was one of the groups. The Asian Women's Network and the Romanian community. Real CIC. I don't know all these organisations yet. And the dads, yeah, working with dads and new parents as well. So it'd be a rolling monthly programme that we would promote as a PCN.
I think that's an easy one, isn't it? Yeah. I think that's doable. Don't you? Have a monthly cycle of like the groups are all there, big campaign across all the practices. This month is smear month. You know, drop in smear clinics, turn up, get a free sticker. I don't know, what would you want? Maybe not.
To your GP surgery. So we were saying that to go out and actually speak to those ladies and reassure them that, you know, we can put extra screening up, we can make sure it's a female, we can do whatever it is that they want that will make them feel comfortable to come and have their smears done. The same with immunisations. We were saying that we would target, so a lot of the groups that we've got in our areas are targeting families that, you know, live in extreme poverty and things like that. So we would target those groups because they're already up and running. They've already got a good following of people that we want to target. So we would go in and actually speak to them on the ground and say, look, this is, you know, and explain it to them, because sometimes it's just that they don't understand. And we were saying about with the COVID vaccine, that's caused some uncertainty now, which will knock on for other vaccines. So it might just be that you go out and you have a conversation with them about childhood immunisations and give them a bit of, you know, and then they can understand it and they get it better.
There's no reason why people have to come in. So like you can do smear clinics anywhere. It's very low tech actually. You can do immunisation clinics anywhere, as we found in COVID. Like, we never thought you'd do an immunisation clinic in a cathedral and in the shopping centre, and we did. So some of this is even like, you know, I think there's real value in going out. If you've got a women's group that meets on a Wednesday anyway, can we do their smears whilst they're also doing whatever else is going on? Because that barrier of coming in is still coming into our space, isn't it? And actually, if you think about the trauma-informed stuff, coming into our space is part of the dynamic in it all. So there's lots of things to try, isn't it? It's kind of, when I talk about smears, I talk about the kind of probably 50% of women who just need lots of reminders to come. Then there's like 25% of women who need a conversation. That's probably normal primary care. And then there's a cohort that needs something else, isn't it? And the something else is often quite different. So, you know, over the years we've done like henna and smear day, which bizarrely went well. Come and get some henna, have a smear done. You know, we've done stuff out at other locations. We've done smear clinics where everything else is closed. So, you know, come on a half-day closing, everyone else has gone off to training day, and it is just very quiet, one person in the, a receptionist and one person in the building, and there's no one going to see you. There's lots of ways of doing it that's manageable when you get your cohort smaller. So you've got to do normal primary care well, because you've got to get most people through the bulk of the normal system of you, and then it's all these bits on the side that are helpful. Cool, yeah? So I like that. Rolling propaganda, rolling programme. Lots of engagement, working with community organisations. Yeah? Right, anything else we can do? Any other ideas? Is that a no? Well, you wanted to remake the whole of the A&E system. I thought that was a little ambitious for 10 minutes. Right, go on. Right, go on then. You like your idea. Good, go for it.
Other people might not, but I like my idea. I just think that there's a certain amount of patients that keep coming through the door, keep using appointments. For example, body aches. There's something else going on. The GP never gets the chance to actually spend the time to find out, well, what actually is going on. So something like, obviously, maybe a coffee morning, a regular meet, a regular drop-in, where you can target these people and say, come and have a coffee. You have relevant people in the room that are trained to actually recognise what's going on or can talk to them more professionally, but on the surface, it's just a coffee morning. Come and have a coffee with your practice staff. And then if they're regularly coming in, I think then as the conversations go, you can actually start to unpack and de-layer what's going on, and then maybe help these people go down a path that they need to go, rather than just come back again for body aches and things like that. Because number one, you're using so many appointments for the same thing. There's a limited amount the GP can do in that 10-minute slot, but there's more going on.
The recurrent patients are really interesting. So if you have, I think if you have a conversation with clinicians about recurrent patients, and a group of clinicians broadly decide that everything's been done, then you know there's very unlikely to be anything really sinister. So then you do need a different tactic for them. And that tactic is not often medical, actually. So things like coffee mornings and social clubs and is all really helpful. And you tend to get small numbers, but they can be really effective. I love the underground coffee stuff, because often some of these women really struggle to come out without the excuse of going to the doctors. So if you do a coffee morning that they can tell everyone they're going to the doctors, they're allowed to come. But they can't come just for a coffee morning. So there's a few things you can do there is, and you don't necessarily need a doctor in the room. You need someone who yabbers away and talks rubbish. No. Yeah, gets people talking, and often it's connection and anxiety and purpose. And we have a really funny one at Hollinwood, which is a bunch of guys who are all alcoholic. They're still all alcoholic, but they come and they do the gardening at Hollinwood, and they are planning. One of them works for the Parks and Gardens and has promised them all a decent pot in the cemetery. Anyway, but it's all very strange. But medically, their car crashes. They're not any closer to giving up alcohol, but they do come and they do grow things, and then they give their vegetables that they grow to friends. And it is like a dysfunctional, functional group. And that is actually quite important. There's nowhere else they can do that. So, it's not very good medicine. It's small numbers. It doesn't change your population health quaff thing, but it's safer, and they are better. And they do have less appointments for weird and wonderful things. So, good one. Any other ideas? Any other ideas? Go on, Liz. You don't need it, no.
Yeah, you don't need a big space to make a garden. At Hollinwood, there are just literally a few raised beds. It's probably only about, 3 metres by 5 metres. It's not big. And the veg that they grow makes the soup that they then have for their lunch.
So at Hilltop, they had this gardening project come, and I didn't realise what happened, but they put these big bits of cardboard down and covered them in soil just in the middle of the grass. And when I went, it looked like those 2 graves had been dug. I was like, crikey, what have we done? Anyway, apparently it's a gardening project. Yeah. Right, I've got another idea over here.
We were actually talking about it at teaching for our training program the other week, but it's a larger scale piece of work about coding and the computer systems in place for gender identity for trans healthcare. EMIS is not great for that, and at the moment pretty much the only way to flag it up is a horrible term, but is to put an alert on, which doesn't feel humane and isn't very safe. So it's a much larger piece, but at some point that's something that we were talking about.
Coding, brilliant, yeah, and transgender stuff. So coding generally is your friend. So I like little coding projects. Coding things helps you find them again. So even coding, there's lots of wonderful codes on EMIS, but even coding like at risk of social exclusion, just little helpful things, you can find them again. It's quite helpful. So yeah. Any other projects we want to do? So the final one that I'm going to tell you must do is immunisations. So just in GM we've dropped below herd immunity, haven't we? For the first time in quite a long time. So immunisations is a real pickle at the moment, and I think that's one that I'd really like. I think PCNs would be really interesting to talk about. So if we talk about the cohort, how many kids have we got to see that we just need to keep getting our receptionists to ring, and we need to get our nurses to ring, and we just need to normal general practice? How many of them actually require somebody to go and door knock, somebody from their community to go and door knock? Have we got vaccination champions in our Roma community, in our Bengali community, in our whatever? You know, we need to kind of be mobilising, don't we? And that's across GM. It's not just sunny Oldham, but immunisation is one that would be great for a health inequalities project. Cool. So I think we're going to come to the end of our day. Is that all right? You can all dip under the traffic. Has it been useful? Yes. Okay. We have a think about it. We were thinking about whether we do this again later in the year, mainly because it just provides a space for people to think and learn. But we don't want to do anything that people don't want to come to because it's a waste of time. But so have a think if you think it would be useful later in the year as we head, not maybe in September before we head into winter madness, but things. And the final thing to say is that the team from Shared Health have been amazing. So Sam, who's pulled the day together, thank you so much, Sam. And generally, if you want some help with health inequalities, you can contact the Shared Health team. So what they're really good at is finding solutions for like pickly problems that will help your project move. So there's a little bit of funding, but more than that, they're really good at going, okay, you need someone to employ those people. You need this kind of practical stuff done. You want this bid to be read. You want, all those kind of things that actually at PCN level, there's no one there to help do that, or PCN managers feel a bit overwhelmed. So they're kind of really good at sorting that out and putting support around projects to kind of make them grow and work. And you've seen some of Jen's stuff today and some of the other things. So feel free to contact them. Feel free to use them. They're there to be used. And yeah, thank you so much for coming. We've really enjoyed it. And I'm generally really chuffed that people turned up because it's always a good thing. So thank you so much. And yeah, we'll catch up with you all soon. Thanks.